Very good morning to all of you. I welcome you all for this wonderful Pulmonology Symposium. I hope you'll have a wonderful session on different topics that we have enlisted today. To begin with, I would like to give you a small introduction of what this organization stands for, what we have in terms of infrastructure, what we have been doing in last 2 years. We are now a 2.5 year old institution, started in September 2014. This is one overview of one of our ICUs. You will notice the beauty of this hospital lies in every bed having outside view, including operation theaters, ICUs and all. This is what we have done in last 2 years. More than 60,000 outpatients, 8,000 inpatient admissions, 2,500 major surgeries, 47 kidney transplant, including one heart transplant. Also bone marrow transplant, the numbers are on increasing side. With many more, we also did 58 rigid bronchoscopies with 25 tracheal stents, probably one of the largest in the state. We have also performed 54 complex bariatric and lap surgeries, 200 joint replacements so far, more than 1,300 angiograms and angioplasties, more than 1,000 ITP and 1,500 anemia patients treated and so on. The hospital is, as you all know, situated in the heart of the city with dedicated separate outpatient department block. We have ECMO and LVAD services. One of my colleague, Dr. Praveen, is going to talk about ECMO today. In fact, we have one patient who is on ECMO and another patient who has just come out of ECMO of more than 20 to 23 days. We have facilities for 3D angiography. We do complex cardiac repairs. We do a wide range of neuro and peripheral intervention procedures and so on. The feature of this institute is again, one of the first and probably the youngest institution to have NABH and NABL accreditation. In fact, the whole hospital was built with the norms of NABH and NABL, so it was a kind of cakewalk for us to get these accreditations. We have NAB's OT suits with transplant and surgical intensive care units, interventional CT suits, ICU on wheels. Another feature is we have one of the best nephrologists who is actually known for doing ABO incompatible kidney transplants. We have reverse isolation bubble rooms. So this is where this institution stands for. We believe in dispensing health and happiness ethically. This hospital is by the doctors, for the doctors. We are into transplant and high-end medical and surgical care deliveries. This is another overview of one of our ICUs. Right from the beginning, we have believed in knowledge sharing, and this CME and many more CMEs which we have conducted so far is a part and parcel of our knowledge sharing intention with all the doctors and other clinicians in the city and around. We are going to conduct these kinds of CMEs in coming future. We have also been conducting, apart from CME, a lot of other training programs, and most of the CMEs, as it is mandatory nowadays, will carry some credit points. Thank you very much for listening patiently. Now may I call upon Dr. Jayachandra sir, who is one of the star consultants, and you all know he is one of the best interventional pulmonologists in the town, to give you an overview of this entire CME program. Dr. Jayachandra sir.
Yeah, morning all of you. Basically, when we plan to have a CME program in our hospital, so we were debating about the topics to have. I mean, we have had enough of talks about asthma, bronchitis, and what have you. Every time you go there, you have talks like this. So we thought we'll talk about something very different and something of current interest. So one of the chosen topics today was to have something to do with the central airway obstruction. Now this is not so often encountered problem, nevertheless one of the most important things because it comes like a bolt from the blue, and this is where pulmonologists are equipped to deal with it. So we are going to talk about different aspects of central airway obstruction, like the medical aspects, how are you going to evaluate, and what are you going to do medically for these people. Then at the other end, we have the surgical approach to the same problem. All these things are tumors and other things with obstruction in these major airways, which can be dealt with by the surgeon. And the new kid on the block, where you have the interventional pulmonology, where you have the interventional pulmonology, which is neither medical nor it's a totally surgical thing. So somewhere in between, where you have a mid ground to tackle all these things, especially for palliation, and may not be a definitive way of treatment, but definitely a clear-cut palliation where surgery is not a feasible option. So you don't let a patient go, but you are able to step in and do something for these patients. So this is the main thing. So medical, interventional pulmonology as well as surgical approach to a central airway obstruction. Now the other two topics are also very interesting. These days, every now and then you keep hearing about ECMO and you talk about swine flu and all that. And quite often we find that a lot of people, we have reached the end of the road, we are not able to ventilate, we are not able to bring up the oxygenation. Particularly in a case where there is a reversibility component, that is when you start thinking of ECMO as an additional option for these people. So we thought, a talk about ECMO would be very much in order, especially in the current scenario. I think we need to talk about ECMO as a extending CME point. Last but not the least, every day we are all faced up with this problem, an abnormal X-ray, interstitial pattern, you don't know what it is all about. Yeah, Dr. Paramjyoti will be talking about the interstitial lung disease and the collagen vascular disease spectrum overlapping and how we are going to differentiate all these things. So I think on the whole, you're going to be exposed to a lot of interesting topics today. So to take it forward, let me ask Dr. Lata Sharma to come and talk about the medical aspects of major airway obstruction. Dr. Lata is a consultant in KIMS, senior person. I have known her for a long time, and she does some very good work, and she also dabbles a little bit in thoracoscopy and other things, and let us hear her out. Yeah, I have a pleasant duty to perform before I walk down to give the podium to Dr. Lata, and that is to give a memento to Dr. Abhijit. Dr. Abhijit. Yeah. It's my pleasure. Dr. Lata Sharma.
Good morning, everyone. At the outset, I want to thank Dr. Hemant for giving me the opportunity to talk in this prestigious institute, and I also want to congratulate him on his 2-year run, successful run. I also feel honored to be sharing the dais with my guru, Dr. Jayachandra, who has always been there to help us with our difficult cases. Now, medical management of major airway diseases. Most of the major airway diseases that we face, and especially in case of fixed obstruction, there is no role for medical management. It is a surgical intervention that helps. But I have selected few cases where it is medically possible with either no intervention or very minimal intervention only to secure the airways. Let us first see the pathological conditions causing the disease. Mucus gland enlargement, goblet cell hyperplasia. These are the two main conditions which lead to excess mucus production, that is mainly in the major airways, loss of cilia, ciliary dysfunction causing airway wall changes, and there are of course the diseases of the cartilage. Causes of upper and major airway obstruction. As you can see, post-intubation stenosis, post-tracheostomy stenosis, benign and malignant tumors, foreign body, vocal cord dysfunction, mediastinal masses, external compression by enlarged vessels. Now, where does the medical management fit in this? Mostly they have to be tackled only by surgical intervention. Before going into the cases, I've selected 8 very interesting cases where we have done some amount of minimal intervention and mostly managed with medical management only. So what are the symptoms of such major airway diseases? There is cough, breathlessness, and of course the most important thing is the stridor. Whenever there is supraglottic edema, this is a general rule, it is inspiratory stridor. Tracheal obstruction, it is expiratory stridor, and subglottic obstruction, it is biphasic stridor. Let us directly go to the cases now. This is a 53-year-old male patient, 125 kilos, severe snoring, apneic spells, frequent awakenings, and daytime somnolence. I think we all know the diagnosis. It is obstructive sleep apnea. Now he had come to our hospital for any sort of surgery which can reduce his weight, either bariatric surgery or upper airway surgery. That's what he wanted from our hospital. Now pre-surgical evaluation, it showed that he had resting hypoxia and then elevated TSH, both risk factors for future any major surgical intervention. So we went ahead with a polysomnography. As you can see, AHI is 78.3, that comes under the severe category. Desaturation to 54%, that is the least saturation, that's very severe. And with only CPAP, without any BiPAP, only CPAP, it improved, AHI improved to 2.3 and oxygenation improved to 89%. In such case, where you can clearly see an improvement with only intervention and splinting of the airways, do we really have to do any surgery for this man? Can we wait for some time? Can we wait for the hypoxia to clear? And can we wait for the TSH to also come down so that the risk can be reduced? So Cleveland family study shows that these are the risk factors for OSA. Obesity, definitely this man has it. Genetic, probably. Craniofacial familial features in the form of retrognathia, hypognathia, they were not there in this gentleman. Aging, he was only 53. There was no history of smoking and alcohol. So if we consider only obesity and probably some genetic features, can he have OSA only because of obesity? Wisconsin sleep study definitely shows that 10% weight gain can occur whenever there is a 6-fold increase. Whenever there is a 10% weight gain, there is a 6-fold increase in the odds of developing moderate OSA. And 10% weight gain also worsens the OSA by 30%. We initially did not want to take him for any surgery. Comprehensive approach we had to accept. One is extensive counseling sessions we had not only with him but with the family members also regarding his lifestyle, and we accepted a 3-month or later on a 6-month target. We asked for a nutritionist advice, exercise, and he asked for a yoga therapist also, that also we provided to him, and of course the most important, CPAP. Now that is what he is now. He was very happy to share the photos with us. He was 125 kilos initially, and after only 5 to 6 months he reduced to 85 kilos. You can see he's a jeweler and he loves his job, I think. Now, does CPAP lead to change in BMI? Clearly, there are very interesting studies which show that CPAP was associated with weight gain in some, not weight loss. CPAP may affect weight in many ways not measured. Physician should stress an active weight loss plan and not assume CPAP alone will lead to weight loss. So that's a very interesting finding, saying that it's not only the CPAP, but there are multiple factors involved in the weight loss of the patient, like the comprehensive approach that we had accepted in this patient. This another interesting study which shows that OSA patients using CPAP may gain a modest amount of weight, with the greatest weight gain found in those most compliant with CPAP. A person who is very compliant with CPAP and accepts the CPAP every day for at least 8 hours per day, he has a more chance of weight gain. Now, what is the reason for this? The reason for this is The weight gain, it is a balance between energy expenditure and energy intake. During the nights in these severe OSA patients, there is supposed to be a very, very difficult phases of sleep where there is increased energy expenditure due to increased work of breathing. So what is the CPAP doing? CPAP is reducing the work of breathing, reducing the inflammation of these patients, and probably, and he breathes well, you are allowing him to breathe well, giving rest to the respiratory muscles, and probably that also is one reason why his weight gain is not coming down. So it clearly shows that it is not only the CPAP but multiple other modalities in the form of lifestyle modification which are important in these severe OSA patients. Now this is case 2. This is a 15-year-old male patient diagnosed as ischemic stroke. He came with vomiting, pooling of secretions, and had to be intubated for airway protection. MRI confirmed the ischemic stroke, and the neurosurgeons decided for conservative management. TP's, he was intubated initially, so TP's trial also was done, which was successful, and the patient's saturations were normal, he was breathing normally, and chest X-ray also was normal, so they decided to extubate the patient. Within few hours, he had to be re-intubated. It was a little difficult intubation, and another unsuccessful extubation trial also was done, and later on they had planned for a tracheostomy. I was involved in seeing the patient at this stage. Clearly the history is suggestive of some sort of obstruction somewhere in the upper airways. So I attempted a bronchoscopy for this patient. This is what the bronchoscopy was showing. It was still in the throat. So you can see there is severe edema, that is a supraglottic area. Hardly you can see the vocal cords, you can't see them. And these two films, this is when we closed the tracheostomy and deflated it and allowed him to breathe. This is what was happening. It was totally closing, caving in, absolutely no place for, you can't even see the vocal cords there. So this is supraglottic edema, caving in of the edema causing total vocal cord obstruction. This is one of the most important causes of failed extubation when you rule out other causes like post-intubation granulomas, and it is really undiagnosed and there is spontaneous regression basically. So you give it rest, and within 1 to 2 weeks it goes away. This is a condition called oropharyngeal dysphagia. This usually occurs in patients who are intubated, or there is a history of vomiting, or in patients who have altered sensorium. There is inflammatory response, increased secretions, presence of edema, and altered swallowing process that leads to inflammation in that area and causes edema. Medical management, can we just wait for the patient to recover, or are there any medicines available? There are some proteolytic enzymes like trypsin and chymotrypsin preparation. There are few case reports also which show that there is improvement with trypsin and chymotrypsin. I have not used this for this patient. These oral proteolytic enzymes modulate the inflammatory process, reduce the edema, and decrease the capillary permeability. After 2 weeks, we again attempted the decannulation trial. That means we closed the tracheostomy, deflated it, and he was breathing normally without any evidence of stridor. So I did not do another bronchoscopy, and we could easily extubate the patient after 2 weeks. The third case, 77-year-old female, presented with dysphagia, stridor, and asthenia of long-standing duration. Saturations were normal, X-ray was normal, but there were some other findings which were abnormal, like low hemoglobin, high ESR, and high creatinine. Because of the long-standing non-specific symptoms, we wanted to evaluate her further before going for any endoscopic procedures in the form of bronchoscopy. Patient had come to us in a wheelchair, looked very asthenic. So we did some electrolyte examinations, and can you find out what is the problem? Calcium is very low, phosphorus is high, and PTH is also very low. The normal range is 15 to 65. So this is hypocalcemia induced stridor, and she had multiple episodes of this. So what does this mean? Hypocalcemia is more common in pediatric age group. It's rarely reported in elderly people. The symptoms are circumoral numbness, paresthesias, muscle cramps, laryngospasm, seizures, and myocardial dysfunction if it is severe. So we gave IV calcium replacement, and we were planning to do an invasive procedure, bronchoscopy basically, if there is no improvement. But there was dramatic improvement next day, and within 2 days we could discharge her and with a calcium of 8.3, and we kept checking her calcium. She never had the episodes of stridor later on. We published it in Indian Journal of Endocrinology and Metabolism. This is a case of 17-year-old male with suprasellar SOL, diagnosed as craniopharyngioma with hydrocephalus. Tumor excision was done, and post of day 2, patient had breathlessness, stridor and desaturation. He was intubated. There was failed extubation, and he had to be re-intubated, which was there was little difficulty in intubation, and ultimately tracheostomy was done. We were involved in this case patient at this stage. I did a tracheoscopy initially. I checked the lower trachea and the main bronchi, which were normal, no problem at all. And then the laryngoscopy. Then I did the laryngoscopy. This is what it showed. As you can see, there is fleshy white exudative collection, not only on the vocal cords but in the subglottic area also. There is lot of vocal cord edema. You can't delineate it. That's what it was. Now we just a little bit of suction, applying suction in that area. As you can see, there was a bleeding in that area, and it left a raw area. This is exactly what we don't want, because that raw area is the reason for the granulation tissue. So do we remove it, do we pull it out, peel it out, or just leave it? We thought, because he is only 17-year-old, we did not want to meddle with that patient, and anyhow his neurological status was not great, so we thought of continuing the tracheostomy for 2 weeks at least, and then see the patient back. In the meanwhile, we tried to maintain oral and throat hygiene. Subglottic suctioning was done through the channel that is present attached to the tracheostomy tube. No excessive throat suctioning. We did not want to do that with the semi-hard suction cannula that we constantly use for patients. And we continued tracheostomy for 2 more weeks. So this is what the picture was after 2 weeks, exactly 2 weeks. Cords, they have become normal, and the cord edema also has come down. But when we go deep inside, you can still see that raw area there, and that's the tracheostomy tube. We took a decision to decannulate the patient, and we could easily do it, and he's still under follow-up. He is supposed to come in the next 1 to 2 weeks, and if there is no problem, I'm not planning to do any more intervention for this patient. Just another case. Can you tell us what is this? There is that yellowish fleshy exudative lesion on the cords. One clue is patient is a diabetic. Yes, fungal infection, mucor. Rare case of bilateral vocal, just a comparison to the previous patient. Rare case of bilateral vocal cord mucormycosis. We had it in our hospital. We did a biopsy, and mucor was positive, and it was published in the American Thoracic Society journals. Now 83-year-old male, dyspnea, wheezing and stridor. Multiple hospitalizations, 4 to 5 times in the past 3 to 4 years. The diagnosis was brittle asthma, difficult to treat asthma, and he was never a smoker. So if it is asthma, then what is the reason for the stridor for this patient? He had type 2 respiratory failure, copious secretions, cor pulmonale, and there was one very interesting history. Left pneumonectomy 40 years back. Diagnosis? Stridor and left pneumonectomy. Patients with pneumonectomy, they have increased chance of developing tracheobronchomalacia. So let us see what happened to this patient. We started him on antibiotics, mucolytics, NIV support, and then I did a bronchoscopy for this man. As you can see, there is caving in of the membranous portion of the trachea, almost nearly closing the trachea at this level. This is during inspiration, and that is during expiration. That is the reason for the stridor. So there is flaccidity of the supporting tracheal cartilage, widening of the posterior membranous wall, and reduced AP airway caliber. In the meanwhile, patient had worsening of dyspnea, stridor, type 2 failure, severe hemodynamic instability, and we had to intubate and ventilate the patient. So what is tracheobronchomalacia? It is weak, it's a condition where there is chronic inflammation, infection. These are the risk factors: pressure necrosis, impaired blood supply after lung transplantation, and chronic airway compression caused by substernal goiter, mediastinal tumors, or the vascular anomaly. These are the risk factors for the development of tracheobronchomalacia. It can occur alone or with external dynamic airway extrinsic dynamic airway obstruction collapse, like we saw in this patient. So tracheomalacia post pneumonectomy, it is supposed to be because of the long-standing compression of the cartilaginous rings of the tracheobronchial tree between the great vessels and the vertebral bodies, and it is also because of the marked mediastinal shift. Now, what do we do for TBM in a patient who has history of post-pneumonectomy? Published literature is very limited. Malacia in general is a poor indicator of outcome, and this patient developed symptoms 40 years after surgery. According to literature, these symptoms of stridor and tracheomalacia occur usually 1 year after surgery, and we were unable to explain the delay of 40 years post the surgery. Now, what are the options for him? He is now intubated. Do we do a stenting? Do we do a surgical repositioning of the mediastinal structures? Stenting, we initially considered it, but the patient had type 2 failure. We had to give him NIV, which can be given through stenting also, but main problem with him was the copious secretions. We had to have a port through which we could do a proper tracheal and bronchial toilet. So we needed a port, either in the form of endotracheal tube or a tracheostomy. We ultimately decided to go ahead with the tracheostomy because that would reduce the secretions. We will need a port, and probably we can also give him positive airway pressure through that. Now, after the through the endotracheal tube, I did a bronchoscopy again, and as you can see, there is a caving in. So that is not only in the trachea and the main, but also in the segmental. You can see the caving in here. So this is not only tracheomalacia, but tracheobronchomalacia. So we optimized the medical condition. We continued with the bronchodilators, mucus clearance, and positive airway ventilation. Now we opted for a low tracheostomy. We discussed with our intensivist and our ENT surgeon also, low tracheostomy, and we procured an extra length tracheostomy tube, which goes, and it is almost 2 centimeters anterior to the carina. So these long tracheal anomalies in the form of stenosis or malacia, there is an indication for these sort of long tube tracheostomies. So we continued the BiPAP through the tracheostomy tube, bypassing the upper airway resistance. Because of keeping in view his age, his corpulmonal status, we did not go for a Y stent also. We tried to concentrate only on the main portion, and we were not very much worried about the bronchial part of the malacia. So this BiPAP provided dynamic pneumatic stenting, access to the tracheobronchial tree through the tracheostomy. There was relief from acute respiratory failure. We could correct his hypercarbia. He did not require any oxygen also, and we successfully discharged him with tracheostomy and intermittent BiPAP support with a suction machine available for them whenever there is any need. We published this in the Indian Journal of Palliative Care some time ago. This gentleman survived for a year after the procedure, and after that there was a sudden death incident. He was found like that at night. Now this is another case, post neurosurgery patient, post-operative POD 3. There was respiratory distress, desaturation, and he was intubated in the night. Now this is the X-ray. There is complete collapse of the left lung. So we suspected mucus plugs. The risk factors being depressed cough reflex, sedation, ineffective mucociliary clearance, high cough pressure, and tracheal inflammation. And do we do a bronchoscopic lavage for every such patient who has an obstruction, collapse? We thought we would try initially with medical management in the form of mucolytics. Mucokinetics are the group of drugs which can be divided into mucolytics and expectorants. Mucolytics dissolve the mucus, disrupt the disulfur bonds of the mucoproteins. They reduce the viscosity, and they also have some antibacterial effects, especially NAC, N-acetylcysteine. Expectorants, they signal the body to increase the amount of hydration of the secretions and lubricate the irritated respiratory tract. So we did endobronchial instillation of NAC. We put him in the left lateral position, instilled it inside without the use of a bronchoscopy, and then waited for 5 minutes and sucked out the secretions in the same area, and then turned him the other side so that there is no soiling of the secretions into the right lung. Did postural drainage and then few physiokinetic therapies. Now that is the X-ray. The very next day, so without any bronchoscopy, we could easily remove the secretions, and probably our NAC, the acetylcysteine, also has helped him. But is it so simple in every case? Can we just do away with endoscopic removal? Let us see this 40-year-old male patient who was very obese, 130 kilos, road traffic accident with C2 fracture. So there is no chance of mobilizing the patient or turning the patient in the bed. Multiple facial fractures also, that also was a big problem because he was unable to cough. There was restricted jaw movement. He was quadriparetic because of the C2 fracture. And he had type 2 respiratory failure and he had to be intubated and ventilated. He had a PCO2 of 120 at the time of intubation. So that was the X-ray, total collapse of the right lung. Now when we did the bronchoscopy, you can see those thick tenacious secretions totally occluding. This is just at the tip of the endotracheal tube, and we had to do multiple suctioning. I had done bronchoscopy 2 times for this man, and we instilled the same NAC for this person also. We took the help of mucokinetics, chest wall vibrations, manual lung hyperinflation, and bronchoscopic lavage. He took time. There was some improvement in the initial X-ray, and then after 5 days, the X-ray improved. This is the last case, 59-year-old male patient, is a smoker, hemoptysis of 3 days duration. That's the X-ray, left lung collapse. Incidental finding of this, what is it? Anyone? Saber sheath trachea, yeah, good. And this is the left main bronchus obstruction, occlusion. So you can clearly see it looks like malignancy. We did a biopsy from that area and it was suggestive of squamous cell carcinoma. Now, there is an obstruction in the left main bronchus, and in the CT it shows that there is a mass encircling the left main bronchus and the surrounding structures also. So now what do we do? Do we do a laser excision? You can clearly see there is a mass. What we can see is only a little bit of it. What we cannot see, but see only in the CT scan, is a big mass there. So will a laser excision help him, or stenting, or left pneumonectomy, because he is an ideal candidate for pneumonectomy also, because there is a 2 centimeter length which you can clearly hold. So because the patient was well maintained, he was hemodynamically stable, we thought there is no urgent, there is no emergency reason to take in for any major surgical procedure. So we involved the oncologist and we started gemcitabine and cisplatin. And that's the X-ray with only chemotherapy within 15 days. So we have to follow up the patient, but clearly no surgical intervention was needed in this patient. So to conclude, we have a patient with obstructive sleep apnea, upper airways, no surgical intervention, only CPAP. Supraglottic edema, masterly inactivity, just recovered within 15 days. Laryngospasm, try to find out the cause for that. And it was hypocalcemia, we corrected it, so no intervention. Subglottic granulation tissue, again masterly inactivity. Tracheobronchomalacia, though there was intervention in the form of a tracheostomy, no major surgical procedures or stenting. Left main bronchus occlusion, of course bronchoscopic suctioning, and a tumor we could do away with surgery with only chemotherapy. Thank you. And if the patient does not improve from this will not occur in all patients. If there is no improvement, then there is the next step, and the next speakers are going to take away from here. Thank you.
I think that was an excellent talk about medical management, especially central airway obstruction. When I allocated this topic to Lata, I was wondering how she is going to handle it, because this is going to be a very difficult kind of a thing. And there are very few conditions where you can go ahead and, not involve the IP or the surgical people. But I think she has done an excellent job by trying to highlight the cases, and by giving so many examples, I think she has done an excellent job. And to the topic also. I think all of you would have learned, even I have learned a few things, hypocalcemia and other things to be considered in a stridor, even in the elderly. Pediatric, yes, you would always consider it. Even the elderly, I think we need to look into that. I think she's just highlighted some of these things very well. Thank you, Lata. Yeah. Lata, my pleasure to give you a memento. She's talked about the medical management. I'll go on with the other topic. Okay. Now we'll just talk about, essentially we'll cover like this introduction, definition and all that. So, and then we will take it from there. Basically we are talking about a central airway obstruction where it is a potentially life-threatening problem, and this can be seen in any number of cases. It may be malignant, it could be benign, it could be sudden, it could be slow onset leading to an acute exacerbation, or any of these presentations. Now by definition we are going to talk about airway obstruction which is going to involve the trachea and both the main bronchi. This is by definition we are talking about central airways. Anything more peripheral to this, we do not consider that as a central airway obstruction. And we are going to be talking about most of these things. And this is fairly common, and especially in lung malignancies or even in metastatic disease, you will find at least 20 to 30% of the people going on for an airway obstruction. And these days, with the number of people going on for ventilator support and other things, you will find post-intubation tracheostenosis as a very, very common presentation. You also have tracheobronchial growth, and please do not think that they are so rare that we don't have to consider that. They are not so rare. Once you start considering that, you will diagnose quite a few things. And foreign bodies are also something which you need to consider, particularly in the younger age groups. So what are we talking about here? Which is the pointer? So, no, I'm not getting that. That's okay. Yeah, when you look at the central airway obstruction has a wide range of etiology. Most of the times you're talking about malignancy, and NSCLC is one of the most common disease where you find airway obstruction. So this you will find in any textbooks. I'm not going to be talking about all these things. But let me tell you one thing. Almost all these things I have seen in my career. So probably in your career also, it's quite likely that you're going to be seeing almost all these cases wherein they come to you at one time or the other. They're not very common, but they're not very rare either. So you have to look at it like that. These are the non-medical issues. In our country, I think what we need to consider is this thing, tuberculosis, endobronchial tuberculosis is an extremely common thing when you start looking at it. You find a lot of people who seem to be sputum positive, but the chest X-ray appears to be normal. These are the kind of people wherein probably doing a bronchoscopy will reveal that they have endobronchial tuberculosis, wherein there is a significant narrowing of either main bronchi or even the trachea sometimes. I've had people coming with, mild stridor because of endobronchial tuberculosis involving the trachea, sometimes the left main bronchus, and it's quite common in the left or the right main bronchus having endobronchial tuberculosis. All right. Now this is another thing. Foreign bodies is something you have to consider, especially in children. And in children, let me tell you, any normal child who comes to you with respiratory difficulty, with or without an X-ray being normal, I think do consider a foreign body and proceed further in doing a bronchoscopy. Okay, so in benign airway obstructions, what do you have? Pits, at least in my experience, this is the most common. What is pits? Post-intubation tracheal stenosis. I've seen it starting from, immediate subglottic region within a centimeter of the glottic chink, mid-trachea, distal trachea, precarinal, you name it. I have seen obstructions at different levels, depending on the type of endotracheal tube used or depending on the type of tracheostomy tube used, like Lata referred to a long tracheostomy tube, especially which is placed near the precarinal level. All these things are equally irritant and all of them can potentially produce a tracheal stenosis. I think we need to talk about it. Benign tumors, I will show you some of these things. Sometimes you have idiopathic tracheal stenosis, you really don't know what it is. You find a membrane there which you have a very narrow opening in the trachea and we have to do that. And papillomata are also seen occasionally. These are the other things, secondary deposits, extrinsic pressure and other things. And these are things which you see quite commonly among the relatively benign tumors of the tracheobronchial tree. Now, how does it present? It can, because of different ways that the trachea is involved, it could be either a totally endoluminal tumor, or it could be an extrinsic pressure giving rise to a narrowing here, or it could be a little of both. Little bit of extrinsic pressure and a little bit of breakthrough through the tracheal wall. Any of these varieties or any of these combinations can be seen during your practice. So the entire thing depends on how they come to you. They all present with different kinds of this thing, whether it is a acute on chronic, or it's an acute thing, or it's a slowly progressive disease. And these are the kind of things which you will have to consider. The signs and symptoms develop when it becomes more than 80%, then you start having symptoms like this. Mild stridor, especially on deep breathing or when after exercise, normally the tracheal lumen will be in the region of about 8-9 millimeters or so. Till about 8 or 9 millimeters, you hardly have any symptoms. Mild airway obstruction, you don't, most of them are asymptomatic, you don't even bother about it. The only thing is when it starts to become, when the patient starts to become dyspneic or you start having a stridor, then you start looking at other things. These you see when the obstruction is critical. There is a pooling of secretions leading to an obstructive pneumonia, or it could be a total collapse like she showed when there's a left main tumor which has totally blocked the lumen of the left main bronchus. You could have a total collapse, or you could have a localized wheeze when you're examining a patient. Hoarseness of voice, of course, you would know, especially with the involvement of the recurrent laryngeal nerve. And this is exertional dyspnea will come out only when I said that the tracheal lumen is less than 8 millimeters. So the stridor comes in only when it is about 5 or 4 millimeters, that the patient is sitting across to you and trying to tell you that patient is breathless, that you hear a faint stridor and you know that you're asking for trouble, because we know it is a critical airway narrowing, and that's where you're going to go on. So you would like to evaluate these people by way of non-invasive test first as far as possible before you try to go in and intervene or take any intervention, do any intervention in these people. This remains the basic thing, that you do a chest radiography, and PA and lateral projections are absolutely essential. Then you do a CT. CT is a must, especially once you have confirmed that there is a major airway obstruction, you require a CT. And let me tell you one thing, the routine run-of-the-mill CT scan that you get from any of the labs, you can take it and directly throw into the waste paper basket. None of those things are useful at all. You will need to tell the radiologist exactly what you're looking for. You want a total tracheal reconstruction, and you want to see the degree of tracheal obstruction. You want to see the length of the tracheal obstruction, and if they have reconstructing the entire image, they should be able to do a multiplanar tracheal reconstruction. I will show you how it looks. You do that, so that is when you know exactly how to deal with these things. Pulmonary function test, yes, you do that, and you say this flattening of the flow volume loop and other things. That comes in only when there's a critical airway obstruction. And most of the time when the patient is so critically breathless, I don't think we really need to go in for a spirometric evaluation, because that's not going to add to our information. So I prefer not to go in for a spirometric examination, especially in a person who's come with stridor. He's already so dyspneic, it is really unfair on our part to ask him to go through with a spirometric examination. So whenever you take a chest X-ray, please ask for a penetrated film. This is absolutely essential because you need to see the air bronchogram to be able to decide whether there is a narrowing at all or not. Otherwise, you'll be missing underpenetrated films. They do not show the trachea or the bronchi, so you will not be able to pick up anything at all. So if you want to offer anything more, what a run-of-the-mill physician is going to offer, you should be equipped. You should know which X-ray is acceptable to you. You have to go back to the radiologist and say that this is what I want. You should know what you want, and you should ask for a properly penetrated film, and you should be able to see the tracheal air column or even the bronchial air bronchogram. You should be able to see. Now, all these things, of course, they are self-explanatory. You know that there is a lung collapse or a lobar collapse. You know exactly where the obstruction is. So all those things are most of the time there are inferences as to where the thing is. But please remember one thing. You could have a normal chest X-ray, but still have a major central airway obstruction. Particularly if there is a narrowing at the level of the carina, you may not find anything at all except for bibasal patchy opacities because of retained secretions. You could have a carinal growth of significant degree of obstruction. The chest X-ray may be normal. So please consider all these things before you think of all this. Now this is what I am trying to talk about. You look at the tracheal air column, you are able to see it so clearly. This is the kind of penetration that you would want. Forget the parenchyma. You are not interested in the parenchyma in these kind of people. So don't say that I want to look at the parenchyma. I should be able to see the vertebral bodies very faintly and other things. This is all for the theory. That's only for other parenchymal diseases. When you're trying to talk about airway diseases, we want a properly penetrated film. You should be able to see a proper, you can see the left main, you're able to see the carina, and you can see the right main bronchus. This is absolutely essential for diagnosing any of these conditions. And look at this. This also, even though this is a bedside picture, this doesn't show very clearly, but faintly you can see that there is left main is obstructed here. There is a patch of pneumonia here, but left lung is completely obstructed here. So these are the kind of things that you're looking for when you're dealing with it. Or sometimes the corollary is true. When there is hyperinflation here, this is not a collapse here, but there is hyperinflation which is pushing the lung onto the other side. That is, there is a valve mechanism operating in the right main bronchus. This is a child's X-ray, so first thing you would consider is, are we dealing with a foreign body here? Any child who comes to you with this kind of a picture, or even a normal chest X-ray for that matter, please, if they are stridorous, if they are breathless, please evaluate the airways. If you are not able to make sense out of the X-ray, feel free to get a CT scan done. Please do not ignore the thing and say the chest X-ray is normal, there's nothing, you come back after 1 week of derifilin or some nonsense like that. In a child presenting with acute breathlessness, merits a bronchoscopy irrespective of the fact whether the chest X-ray is abnormal or normal. So this is what I'm trying to say. CT scan, this is not the routine run-of-the-mill CT scan that you would see. Look at the image reconstruction. And this is what we are asking for. When you do this, you see this. There is an obstruction here. This you would have not picked up if you have got a routine CT scan done. So please ask for a proper tracheobronchial reconstruction. And why am I saying multiplanar? All these things are not seen on a single plane when you look at it like this. You have to reconstruct the entire picture like this so that the trachea, the carina, the right main, the left main, all of them appear to be in the same plane. So this is a multiplanar reconstruction, and that is where you pick up this kind of thing. You know exactly where it is. This is the distal left main bronchus. This is what we are going to look for. So these are the kind of pictures we are looking at. Even this, when you look at the reconstruction. Look at the degree of tracheal stenosis here. This is subglottic stenosis, narrowing, and you also know exactly the length of the stenosis. So you know exactly how you're going to deal with it. Somebody who comes like this with stridor, some of these people, they say, no, let us immediately do a tracheostomy, he's got a stridor, let us relieve that. Probably this is so low that even if you do a tracheostomy, you won't be able to reach the tracheal lumen. You're going to kill the patient in the attempt of doing a tracheostomy. So these are the kind of people where an emergency bronchoscopic intubation is necessary, or a bronchoscopic guided intubation is necessary. So this will give us exactly the degree of tracheal stenosis and also the length of the tracheal stenosis, so that you know exactly how to go about it. So this is what I'm trying to talk about again. Multiplanar reconstruction. You see the stenosis here. When you look at the stenosis, you know exactly the length of the stenosis, you know the diameter. Even if you have decided that this person requires a stent, you know exactly what size of stent to order, you know how to put it, you know what is the length of the stent that you would require in this particular individual. This is the other thing that Lata also mentioned about. This is a EDAC, that is expiratory dynamic airway collapse. These are the kind of people who have a normal chest X-ray, who come with breathlessness. And they are so breathless, you don't know what is happening there. You do a spirometry, most of the time they won't be able to do a proper spirometric maneuver, so you may not be able to pick up. So you do a dynamic CT, wherein it is done both under expiration and inspiration. And this is during expiration, you find that the entire posterior wall is herniating into the lumen, giving rise to a significant degree of narrowing, causing respiratory difficulty. And these are the kind of cases wherein you will require a medical approach rather than a surgical approach or an IP approach. You can put in a stent there, but most of the time this is so diffuse that it may not be very helpful at all in these people. Probably these are the kind of people who do very well with a BiPAP or BiPAP support, and those are the kind of people who will do well with that. Now these are the kind of flow volume loops that you see. You know, when there is a very significant narrowing, 4 millimeters orifice, probably this is how the flow volume loop is going to look in. But it becomes bigger and bigger. So as I told you, in a critical airway narrowing, doing a spirometry may not be of much help. Okay, once you decide that the patient has got a critical airway narrowing, what do? It all depends on how they present and what the emergency is like. Sometimes it's a life-threatening central airway obstruction. You don't have time. You don't have time to think of a CT scan, multiplanar reconstruction, do this, do that. You can't do anything. Just go in with a rigid bronchoscope. That is the only thing which is a lifesaver there. You just go in with a rigid bronchoscope. You should have a training in rigid bronchoscopy to even attempt it. Otherwise, you're going to puncture the trachea through and through. So what you need to do is go in straight and probably go in through the tumor to establish an airway. And then you start looking as to what is the cause of the thing, what you need to do, and other things you'll have to think of much later. So these are the other things wherein you have a non-life-threatening central airway obstruction. So this is where it gives you some time to plan. So you do a CT scan, you know the size of the tumor, you want to see how much of a extra tracheal or extra bronchial extension is there, whether your intervention is going to be curative or is it going to be a surgical candidate that you need to send him for a surgery. All these things you will have. And then I will show you a little bit of both these things, the illustrations of both the things, so that you have exactly a idea as to how to go about it. Now to cut, these are all basic things. You need to oxygenate, you need to do all these things and see what you can get to establish an airway immediately in all these individuals. So when you're planning for a long-term management, what you need to do is first is creating the base. You have a tumor in the trachea, you remove the tumor, you know it's going to grow back. So even if you want to think of placing a stent or something like that, you have to prepare the airway which is good enough to receive a stent. So the procedure will be to remove the tumor first and then only plan for putting a stent. Or in cases like post-intubation tracheal stenosis, you dilate once. If it has recurred, then you'll have to dilate again, create a proper lumen before you put in a stent there. These are the kind of cases we'll have to think of. And stent placement is done when there is no other choice available. That is, patient is not a fit candidate for surgery. He can't go in for surgery, or he has come back with a restenosis after surgery. Those are the kind of cases wherein you would like to put in a stent. Stent is excellent for palliation. But as definitive treatment, I'll tell you, when you put in a stent, you're buying a lot of trouble. So be careful about putting stents. I'm talking about it after putting hundreds of stents. Then I realized that you know, I'm very reluctant to put a stent unless there is good enough reason. And I know that after I remove the stent, the filler is going to be okay. I'm going to be very, very choosy about my patients where I'm going to put a stent. I'll show you where I have put it. I'll tell you why I have put it. I'll tell you the results also in this kind of people. So most of the time when you're looking at it, we are looking at doing a tumor resection. How we are going to do that and all that, I'll show you one by one. It could be a tracheoplasty, it could be just only a dilatation, emergency dilatation, or sequential dilatation using a balloon or a rigid bronchoscopy as a this one. I'm sorry, this is not showing up very well. But basically what you do is either you use a rigid bronchoscopy. What's happened? I'm not able to read it either. So essentially what you're talking about is you can go about any tracheoplasty or bronchoplastic procedures by multimodality approach to the whole thing. So your base is going to be a rigid bronchoscopy. Then through that you normally use a flexible bronchoscope, a video bronchoscope, and through that you use multiple instruments. Or the entire procedure can be done with a rigid bronchoscopy itself. Using it as bougies, you use the smallest rigid bronchoscope to go through with a tracheal stenosis, dilate it, and keep on dilating it, using it as a bougie to get the maximum, that is, you put a 14 millimeters to come to the maximum size of the trachea. That's how you're going to approach the problem. But it's always, you're not going to say that I'm going to use only a rigid bronchoscope or I'm going to stick only to a flexible bronchoscope. No, it doesn't work like that. So it's usually a combination of all these things. And in an interventional pulmonology suite, we need to have all these things. You will require the entire rigid bronchoscopy system, you require a flexible this thing with all the accessories, like you could have a snare, you should have a cautery knife, you should have a bulb cautery, and you should have a spray cautery, you should have an APC, and if you have a cryo, but it's a luxury, you can have that. But these are the kind of things which are absolutely essential when you're thinking of doing a I'm sorry, these things are all not showing up very well. But let me tell you one thing, all these procedures, whether it is a coring of the tumor, whether it is burning of the tumor, whether it is complete laserization of the tumor or any of these things, these are all done under controlled conditions. Controlled conditions meaning that yes, it is done under GA with the anesthesiologist being there and absolutely clear-cut understanding between the anesthesiologist and yourself, because you take care of the airway. Anesthetists do not want to give over their control over the airway. But in IP, you are in charge. You take charge of the airway and not give him access. I'm not saying that you fight. What I'm saying is we are much better at handling the airway rather than the anesthesiologist, particularly in cases like this. Because when there is a huge growth sitting there in the trachea, anesthesiologists can do nothing to secure an airway for you. So you are the person who's able to give them an airway either by going through and through the tumor and giving them a lumen for him to ventilate. You give it to him, he won't know what to do. The endotracheal tube will not go in. Even the smallest tube sometimes does not go in at all. Most of the times when you are planning for any interventional procedure, now the idea is we want it to be least traumatic. This does not mean that you cannot see blood on the field. That is impossible. When you're cutting, when you're coring, when you're doing all these things, you'll find a lot of blood. One, you have to get used to the sight of blood in the bronchoscopy vision. It is going to be there whether you like it or not. But try not to handle the tissues too much. A balloon probably is much better to dilate a tracheal stenosis rather than using a rigid bronchoscope forcefully to dilate the thing. So what you would normally do in this kind of cases is you take electrocautery, you take radial incisions, especially in a post-intubation tracheal stenosis, you take radial incisions and then you put in a balloon, dilate it to the maximum so that you have a lumen of about 14 millimeters or something. Most times it doesn't bleed that much. And if it is the first time you are doing a dilatation for a post-intubation tracheal stenosis, do not consider a stent, leave it like that. And most of the times with a single dilatation, patient is perfectly okay. If it tends to recur, then you go on and do whatever you need to do. And for taking these incisions, you have multimodalities again. You have electrocautery, you have laser, and you have cryo. Cryo, of course, is not for any emergency conditions. But if you look at electrocautery or laser, which is better? I'll tell you, both of them serve exactly the same purpose. Laser sometimes has got some advantages, but let me tell you one thing, it is very, very expensive for an individual. Electrocautery will do the job just as well. But in a highly vascular tumor, and where you want to have a non-contact kind of a ablation of the tumor, laser has got a decided advantage, because you're going to have a no-touch technique, and from a distance you fire your laser and you can burn off the entire tissue, thereby avoiding a lot of blood loss or even significant bleed, which can again compromise the airway. So the kind of lasers that we use commonly are CO2 we don't use much, but the ND-YAG is one thing that we use very commonly. But in our hospital we have a thulium laser which we use to advantage, and the advantage is it is used both for urology as well as for endoscopic work. Thulium laser is exactly the same purpose as ND-YAG, so it can be done. It is extremely good. Laser energy is absorbed by the tissues very well, and the temperature raised, and it just ablates the tissue by vaporization, cell shrinkage, and death. So that is an advantage. Even with a non-contact mode, you can burn off the tissue, which will give us an excellent degree of control over whatever is happening. Again, this is the same thing, use of heat. Electrocautery is the use of heat to destroy tissue, and we work usually at about 25 to 30 watts setting, so that you don't burn off the tissue. And when you're doing using an electrocautery in the tracheobronchial tree, make sure the anesthetist keeps the oxygen FiO2 to around 40, otherwise you're going to have a beautiful fire in the tracheobronchial tree. I've seen it happening, but be very clear that it has to be only at about 0.4 or 0.5. And this heat that we generate with the use of electrocautery leads to a lot of tissue destruction. I'll show you some of the things when I'm showing the illustrations. APC is an excellent modality that we need to have. This is extremely good, especially when you are having a diffuse ooze, or there's a bleed that you are not able to see very clearly. That is, when it is not in the sight of vision, APC is one thing which is going to be of help. So this is a non-contact kind of a mode. So wherein what you do is, when you fire the APC, that is argon plasma machine, what it does, it releases a little bit of argon which forms a plume around the tip of the bronchoscope and goes around the corners also. And when you fire, it burns off all the raw area, thereby arresting the bleeding. So for sites, bleeds which you cannot see, especially in the tracheobronchial tree, I'm not saying that somebody comes with hemoptysis and he's bleeding from the left lower lobe, you fire an APC into the left lower lobe. No, it doesn't mean that. In the area of operation, when there is a raw area and you're not able to exactly see the bleed, probably an APC is going to be helpful to reduce the thing. And the coagulation is only to a depth of 2 or 3, and it's fairly safe in most of these cases. Cryotherapy, this has to be mentioned because there's a lot of talk these days about cryotherapy, cryo lung biopsy, and so on and so forth. This has got one thing, it totally vitalizes the tissue, tumor, cancer tumor, or anything like that. But only thing is, it is not to be used in an emergency. Though I have seen people using cryotherapy, cryoprobe in an emergency also, wherein you try to debulk the tumor by using a cryo and removing it. But let me tell you, it's going to be a very messy operative field. He is going to be bleeding so much when you pull off tissue of a tumor, that it's going to be a nuisance. I prefer not to do that. Probably I would use a snare or something to remove large chunks of tissue. But cryo is one thing which can be used, and you will devitalize the tissue by freezing and thawing multiple times in the tracheobronchial tree. Over the next 2 or 3 weeks, he is going to cough out most of the things. But the main advantage is it does not mess with the cartilage. So the cartilage is going to be intact totally. You are not going to cause much of the damage to the tracheobronchial tree. So let us look at all these things. When we are doing all these procedures, let me be very, very clear. Right from the beginning, that's what I've been trying to say. Only when palliation is required. If it is something which can be sent to the surgeon for more definitive results, you will have to consider that as a first option. Only when they are poor surgical risks, they are not able to be a good risk for any kind of surgery, or you have a surgeon with poor competence in this kind of cases, don't send it. Probably you will be able to do a better job. For a post-intubation tracheal stenosis, tracheal resection, end-to-end anastomosis, probably is the best thing which can be done. But I've seen surgeons who have taken on these kind of cases saying that we can do it, probably for the first time. They have just read the theory about it. I've seen them. They have cut off about 4 centimeters of the trachea. They have an anastomosis. They come back with a restenosis. And that's a much, much bigger problem to handle. So, check with your surgeon. See if he's got enough experience. If he's good, please send it across to him. If not, you do it yourself. Let's not go into cancer and brachytherapy. We don't do much of this, so let me not talk about that. So these are the advantages that you have with all the 3 modalities. You have laser, electrocautery, cryotherapy. And this is APC, PDT we are not talking about. Stents will come about it later on. Laser can be used for endobronchial lesions, cannot be used for these things. Mixed lesion, part of the endoluminal lesion can be handled by a laser. Electrocautery, if you see, both of them have the same kind of limitations. Cryotherapy is only for endobronchial. For this, it's doubtful again. Brachytherapy, let's not talk about it. APC is only for lesions that you can see, but with an intact mucosa, it is not helpful. Only when you have a tumor that you can do that. And stents, of course, we'll talk about it a little later. So, what do you have? For APC, you have an immediate effect. Yes, electrocautery. Yes, cryotherapy. There is no immediate effect. It is only a devitalization of the tissue, which will make it necrose and fall off after 2 or 3 weeks. So there is no immediate effect with cryotherapy. Hemoptysis control, yes, APC you can do it, especially when you can see the bleeding site. Not otherwise. Don't use it for any of the other things. Fire risk, yes. Cryo, of course, it doesn't because it's only temperature, cold temperature, so there's no question of fire here. But fire risk with APC, electrocautery, and even laser. When you're doing that, the sparking is the one which makes it catch fire. If you are having a very high FiO2. Of course, foreign body removal, you can't use these things, but cryotherapy is used to hold on to the foreign body, freeze it, and then pull it out. That is one modality which you can do. This is especially good when you're talking about a blood clot sitting there, you're not able to pull it out, probably a cryotherapy is going to be very, very useful. Same thing with a mucus plug. Cryotherapy can be, cryoprobe can be used to an advantage to remove that. Effect on endobronchial, both these things can damage the tracheobronchial wall, whereas the cryo is not going to damage the tracheobronchial wall. So pre-stent procedure, as I told you, we have to prepare the ground for this thing, and then you use a combined use of flexible and multiple instruments with APC, electrocautery, blah, 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 blah. You do that and create this thing. What are the instruments that you would normally require? This is the short list of things that you should have. But let me tell you, once you have all these things, then you wish you had more. I can assure you, most of the times you have a compromise. You make do with what is available, but by and large, you can never have a complete wish list that you would want, and that's what I keep complaining to our hospital authorities. But that's going to be a never-ending thing. I keep on asking, they keep on smiling at me. So that's how it ends up. Anyway, let's go on to some of the videos which will show you exactly how we do these things. This, if you look at it, there is a significant narrowing of the trachea. And what is this? This is a post-intubation tracheal stenosis. But look at the cartilages. Cartilages are all damaged. They are not of the usual size. They are all smaller, much smaller than before. So here I'm using an electrocautery knife. You're going to take these incisions like this, radial incisions, famously called the Mercedes-Benz incisions. That is one at 12 o'clock, one at 7 o'clock, and one at 5 o'clock. You make these cuts. So what it does, it gives you a plane of cleavage. So it is dry. If you look at it, there's no bleeding there. Now then you're going to use a balloon, which is a 14 or a 15 millimeter balloon. You dilate it to the maximum extent that is possible. And then probably you do not go on and put a stent in this kind of case. First time, don't put a stent. Yeah, this is the other case which I'll show you. Again, a similar case, post-intubation tracheal stenosis. This is a 12-year-old girl who was on a tracheostomy, and she was on a ventilator for almost about a month. She was not coming out, she was retaining carbon dioxide, and she was told, you can go home now. She's not going to survive because she's got a bad problem. And this child was a special child. She had cerebral palsy, and she was operated. She had a VA shunt and all that, and that's the time. More than anything else, they had exhausted their finances. They said you can take her home on this tracheal. Even on a tracheostomy, she is not breathing well, so she is finished. So that is how she came to me. And this is where you see that you have a tracheal stenosis. This is just precarinal. Again, we are doing the same thing, using a balloon, dilating it completely. This child required a dilatation once more after about 6 months or so, but she is now normal without any stent or anything like that. This is more than 7-8 years since I have done this procedure. Now you look at it, this is precarinal, almost involving the left main bronchus. So a post-intubation tracheal stenosis can be in the subglottic, immediate subglottic, mid-trachea, post-tracheostomy where the bulb is there, or it could be a precarinal. So depending on where the tube is ending, it can cause a lot of nuisance there. This is a 35-year-old lady who came with stridor. She was referred to me from the oncologist saying that she's got a malignant tracheal tumor and that we need to do something about it. So she was very, very uncomfortable when she came, and this is where, when you look at it, there hardly a 3 or 4 millimeter orifice there with lot of secretions, and that is what is the problem. And the moment you touch, there is a problem. And if you see that there is an extrinsic pressure, this is a mixed kind of a thing. There is a little bit of breakthrough through the mucosa, and there is a tumor like this. So what we had done was we used a balloon to dilate it to the maximum extent possible, and then use the rigid bronchoscope to go across the thing. I am using a balloon straight away without cutting any tissue, because I didn't know what I was cutting. So I put in a balloon, dilated to the maximum extent possible, and then went through with a 11 mm sheath, go right across. Now you see that I am coring across. So all this tissue is coming out. I am shaving it off the tracheal wall, and we sent it, and we got it as a benign tissue. We didn't know what it was. Subsequently, this lady also went in for a open surgery. They tried to do a biopsy, turned out to be a biopsy. We never had a diagnosis in this particular case. So we, thinking that it was a malignancy, we put in a SEMS. Normally, a self-expanding metallic stent is not placed in young people and in benign disease. Never is done like that. But in this person, we had assumed that she had a malignancy, and we straight away put this. And at the end of it, then it was proved that it was a benign disease. At the end of 6 months, I removed the stent. And she is absolutely normal now. This is one lady who was known to have a tumor. She went on with the tumor for 4 years before the pulmonologist who was managing her decided that maybe you can think of removing it. That's how it was. Till that time, it was known. The patient had 3 CT scan chests which showed the tumor. Nothing was being done. I couldn't figure out why it was left alone. And when I saw it, look at the degree of obstruction. When she's breathing out, I can't see the lumen at all. And this lady is a coronary artery disease. She has coronary artery disease. She's about 78, and this is how she comes. Now what do? We try to snare, we try to remove. We removed the bulk of the tumor, almost about 80% of the tumor. And what is it? Mucoepidermal carcinoma. So that's a relatively benign thing. You see the entire tumor coming out. This is after coring, you remove the whole thing, and then you create a lumen like this. There's a good enough lumen. Every 3-4 months she calls up, I think I want to come back and get a little more tumor removed, but she never turns up. I think she'll come back again in the similar situation where that thing is there. Now what you're trying to do here is, after removing the bulk of the tumor there, you're trying to burn off the base of the tumor so that you devitalize some more of the tumor so that the lumen is going to be intact for some more time. She's going to re-stenose anyway, but she'll have to come back. Being a mucoepidermal tumor, probably, it won't grow so fast, so we will be able to handle it reasonably well over a period of time. You see that, at least we can see the lumen now. So this is pretty good. Patient is going on pretty well right now. This is another one. This is a 35, 37-year-old male who was being treated as COPD. He had multiple inhalers going on for more than 6 months to 7 months before he came to me. And the way he was describing it was quite clear that there was a tumor there, because the chest X-ray was also abnormal. There was a little bit of a fullness of the left side of the mediastinum, just around the aortic arch. So I said, anyway, let us get a CT scan done. I'm sorry I don't have the CT films, but when you look at the CT film, there is an intratracheal luminal growth. There's a huge external component. Now this is one fellow who had an involvement of more than 4 to 5 centimeters of the trachea. So it's not a surgical case at all. This is also a case of mucoepidermoid carcinoma. But look at the amount of tumor he has got. Now you try to remove it. He's got a lumen, at least he's breathing reasonably well. What you try to do is you devitalize the tissue and remove the whole thing. Now the only problem is when you're doing it, you get a good chance that he may start to bleed. And which is what happens. I'm using a cautery again to devitalize the tissue so that it's safer for us to remove it. You devitalize, burn and remove with a piecemeal, you remove it with a forceps. But then what happens, this fellow suddenly starts to bleed, decides to bleed, then you can't do much about it. Now he is starting to bleed here. So the SATs are going to come down and the anesthetist says, sir, I'm losing the airway, you do something. So what you do immediately is use the rigid bronchoscope itself. Rigid bronchoscope, if you remember, is a hollow tube. Okay, there's a big lumen there and you're fitting into the trachea. You go through and through the tumor, straight along the length of the tumor, and there you have come to the situation where you have come to the carina. The tumor is lying there. Now you remove the tumor. Now what happens is the wall of the bronchoscope itself will tampen out the bleeding. So there will be no significant bleeding even if you have gone through the tumor. And this is where, once you remove it, the base is not bleeding if you really look at it. Then you cauterize the entire thing. Probably this is one guy, we could have given him some quality of life with a stent there, probably a silicone stent or something like that. He would have gone on for a much longer time. But this is one fellow who couldn't afford anything. He says, sir, nahi hota jitna din jiya, utne din theek hai, and he went off. He couldn't really do much about it. So with all these things, removing the tumor itself may be a solution, but sometimes you know the tumor is going to grow back, and especially in a critical area, and that is where you're going to think of putting in a tube. A stent is essentially a hollow tube which will keep the lumen intact, and that's how you're going to go on. I mean, time-wise. Okay? Right. So the kind of stents that you have have silicone, you have metallic stents. These are all self-expanding metallic stents. They just come at the small tube of about 6 millimeters to 8 millimeters diameter. So you can put it over a guide wire, or you can put it directly through an endotracheal tube, or you can do it directly. That's not a problem. But a silicone tube will require a rigid bronchoscopy to place. This is a Y stent, you have straight stents, but these are different kinds of stents which are available. This is again a self-expanding metallic stent. So the selection of the stent, it depends on the degree of obstruction, the length of the lesion, or whether it's a simple or a complex stenosis, and that's what you need to decide about it. So these are the kind of cases. This is one patient who has come, and she was referred from the periphery saying that she is having a stridor, and I have found a growth in the subglottic region. So, sir, please look after this. That's fine. Only thing is, this person who had referred this case had taken a biopsy before sending this case. And this, you see, is a clot sitting over the tumor. So apparently she bled after the biopsy, making it much worse. So she came in on an evening. I said, we'll do it tomorrow, the next day afternoon. But then she was looking so uncomfortable. They said, no, we have to take her on immediately. We took on immediately, and you see how it goes. We try to remove all this gently, try to do that. Nothing works, and they start to bleed. I didn't know where she was breathing from, because I could see no lumen anywhere. She was breathing nevertheless, but the moment you put her under anesthesia, you don't know, she's going to close up. Using a cautery, and what do you find? Only blood, no airway, no nothing. And these are the kind of cases wherein you will require to go in straight with a rigid bronchoscope. Push through and through. There you are. I've already reached the trachea, I've gone into the lumen. But here you see the tumor sitting there. That means I have poured out the entire tumor. Now it is sitting at the carina. All I need to do is remove this tumor from there. You remove the tumor. At least we made sure that there's a lumen there. This lady we put in a SEMS. Then this was because of a thyroid malignancy. Subsequently she went in there She went in for definitive treatment of the CA of the thyroid. The bulk of the tumor is still sitting there. You look at that. So these are the kind of things wherein sometimes in an emergency you will have to do that. Saying that, you know, I'm going to wait for a CT scan to come in, I want to see how big is the tumor. You don't have time. You just have to go in straight away and give an airway. Adenoid cystic carcinoma, after 8 years of follow-up, this gentleman had multiple, look at the carina, look at the carina. This was after removing 80% of the tumor from the tracheobronchial tree. This is how the patient is. One day we removed all the tumor, the next day we dilated him, gave him some time, and then decided to put in a Y stent. We put in a Y stent. This is a self-expanding metallic Y stent. We put in there so that he has a patent airway at least for some, as long as he is alive, at least his breathing difficulty is not going to be so significant. This is the right main bronchus and this is the left main bronchus. But unfortunately, with all these stents, let me tell you one thing. You put in a foreign body in the tracheobronchial tree, it's going to be irritating and it is going to be causing a lot of granulation. And that itself will add to your problem of having respiratory difficulty. So you need to be able to constantly look at them, keep on burning off the granulation so that you keep the airway patent. So these are all palliative procedures. So let us be very clear that this is what we need to do. This is again, look at Wegener's. This is a 22-year-old girl who was referred to me by a pediatrician who knew her, saying that she is under care of some pulmonologist. She was admitted into the ICU of some hospital and she was given enough of steroids, and when there was no wheeze, nothing at all, they said, "You are perfectly okay, go away." And the patient refused to believe that she was okay. And this was the very next day that I did the bronchoscopy. And when you look at it, look at the tracheal lumen. There's hardly a 2 millimeter lumen there. And with this she was discharged, not against medical advice. The patient was discharged saying that you're perfectly okay. And look at the lumen there. So this is one thing wherein we had to, again, you see that rotary movement of the bronchoscope. We had to do a coring for this particular individual because she's bleeding like this. So we had to remove the whole thing. The biopsy did not reveal anything. It did not reveal any granulomata. It is only, she also had an ocular lesion, and from the ocular lesion they had already biopsied before she came to me, and that showed up as Wegener's. I said, this is Wegener's granulomatosis on a bronchoscopic appearance, and they considered that, and then they looked for a granulomata. Then they finally found that she was having a Wegener's. I had put a stent for her, removed it, replaced it again. After about 3 years, I was able to successfully remove this one. Enough of those gory pictures. So this is an interesting case, not particularly pertaining to not particularly pertaining to an airway obstruction, but this is how people present to you. CA esophagus, had surgery, had a gastric pull through, perfectly okay, but having a lot of cough, not able to swallow anything, having a lot of problems. They didn't know why it was happening because they did not deal with the trachea at all. They didn't touch the trachea at all. They just had a stomach pull through, and this anastomosis was done through the neck, as is usually the case. So we didn't know why it happened, but the patient was continuing to have this. When we did a bronchoscopy, we found a tracheoesophageal fistula, which I don't think it was related to the surgery, but I don't know why. I couldn't figure out why why this person had a TOF. Look at the amount of secretions that you have in these kind of people, and that is what causes a lot of stridor or a difficulty in breathing for most of these people. Fast forward it again. Look at the amount of secretions that you find here. You see faintly some bubbling here. You look at it here. You find the opening here. Beautiful hole leading to the esophagus. This doesn't look diseased, doesn't look like any infection there. I don't know what are it, almost like a punched out lesion in the posterior wall of the trachea. There's enough place from the carina to this. There's almost about 4 to 5 centimeters from the carina. So the debate was whether we put a Y stent or whether we put a straight stent in this case. So finally we decided to put only a straight stent. We managed to put it. The moment you put it, first thing the patient asks for is, I want to have my cup of coffee. A South Indian gentleman. And he was so pleased that he was able to have his coffee after almost about 3 to 4 months or more than that actually. I think the video is unedited, so it will go on for a long time. I'll stop there. This is one bedside rigid bronchoscopy that you have to do sometimes in an extreme situation. This is an extreme situation wherein the patient has got a complete lung collapse. Bronchoscope through the tracheostomy didn't help at all. There was no way we could do anything about it. Decided to go on to a rigid bronchoscopy and do that. And rigid bronchoscopy we did. Bedside, patient on ECMO with a platelet count of about 30,000 or something like that. So this was before and this is after. We managed to clear out the whole thing. Probably this is the first time I have done a rigid bronchoscopy on a patient with ECMO for a retained clot there. So I'll stop here. Thank you very much.
After two excellent presentations, as it will have to be, the surgeons will also have to stand up to the occasion. What I wanted to say at the beginning is that it is not a medical problem, it is not an interventional pulmonology problem, nor is it a surgical problem. It is a clinical problem, and I think, as most of you will see, a team approach is, I think, very, very important in these patients. And in some patients, as you have seen, medical management will be right. In some patients, an interventional pulmonology intervention is probably the right thing. But there are also some patients who then will have to be considered for surgery. Sometimes surgery might be the first option, sometimes medical management will be the first option, and sometimes interventional pulmonology has to be the first option. That is the reason why when Jayachandra sir said that we will have a comprehensive symposium on airways, I thought it was very important. It is very important to understand that these are unique problems. These are very, very specific problems. If you see how much of tracheal work I do, in my percentage, it will be less than 2% of my surgical workload probably will be tracheal work. But when it has to be done, it has to be done properly, because as you know, if you lose control of the airway at any time, it is a very, very short time that you lose all control and the patient can die. So what is, as I said, this is the purview of a cardiothoracic surgeon. And as you see, the trachea is in the background, and that's what it is. But when it gives problem, it gives big problems. So where and how do surgeons have to get involved? So there will be issues pertaining to the upper trachea, the mid trachea, the lower trachea, and of course the bronchi. What I wanted to do today was present a few of patients whom I have had experience with, and then take you through the different pathologies. I have to thank Dr. Jayachandra sir for having established an excellent pulmonology unit, and what it means for the surgeons is, in the last 2 years I never did a tracheal resection. I don't have to now, and I think that is the right way. When it can be done without surgical intervention, it should be. And most of the post-tracheostomy or post-intubation stenosis now I think can be safely managed by interventional pulmonologists without having to do with surgical intervention. So where is it that surgeons have to get involved? So what I thought was, I will just present a few cases, and I think that will kind of give you an overall view of what are the pathologies which we as surgeons will get involved with. It could be strictures, more commonly trauma, malignancies, perforations, foreign bodies and some congenital problems. These are the kind of situations wherein surgical intervention might be required. So I wanted to present a quick case. It's a 50-year-old female patient admitted with pneumonia and swine flu positive patient to a peripheral hospital, was intubated and ventilated, and then she had a percutaneous tracheostomy. Percutaneous tracheostomy was fine, she was getting better, and then it was noticed that whenever they were trying to wean her off the ventilator or trying to remove the cuff pressure, she was coughing. Then one thing led to another, and the tracheoesophageal fistula was confirmed. Now, sir had given you a very nice image, and I thought I will take it on from there. So simple measures will be a stent and then trying to close the hole. But there will be situations wherein that might not be enough or that might not be sufficient. So this is where I am telling again and again that an overview is important, and sometimes thinking out of the box is also equally important, and as this case will illustrate. Patient had become cachectic and dehydrated by this time. We are now talking about almost a month in the hospital by this time. They got various opinions. Opinions ranged from doing nothing to an esophagectomy and a gastric pull through. And this is where we were contacted. In fact, Jayachandra sir was first contacted, and sir's suggestion was exactly like what he suggested for the last patient he showed for a tracheoesophageal fistula. He said, soiling the lung is becoming the biggest problem. Let us try and then see if a stent can be placed and whether that will solve the problems. So sir put a tracheal stent, and then the patient was shifted because the patient was quite unstable, and after the tracheal stent, patient became a little bit more stable, and the patient was shifted to Century Hospital. So this is the CT scan. You can see there is a covered tracheal stent covering from where the tracheoesophageal. What had happened was there was a traumatic tracheoesophageal fistula at the time of the percutaneous tracheostomy. That is what was the background of this patient. So repeated microaspirations, and that is what was giving more trouble to this patient. You can see that the lung diffuse changes in both the both the lungs. And for one, what we had decided when she came in was, because at least airway was protected and she was stable, we wanted to nutritionally build her up. And then I wanted to show you.
See. Means where it is exactly at 20.
Sir, ఒక్కసారి లోపలికి
I'll sit up.
Yeah, fine, sir.
Sorry, you see. I can assess almost enter it.
Yeah, it's big gap.
Big gap. Okay.
Yes.
How much about 1.5 centimeters, sir?
It is definitely 1.5, around 2 or and it's less than 1 inch, but more than 1.5.
When we do a primary closure of the
It is
Edges are
see, the moment I come, it is suppose I want to put the insulated stent also, she will always have foreign body sensation.
Yeah.
See?
yeah.
I have got one no space there.
The stent was also not helping, and she had got various opinions, as I said, from doing nothing to an esophagectomy was also referred to. That is when we discussed it, and I said, sometimes you will have to think, how can you give a simple solution to a complex problem? The simple doesn't have to be simple, but whatever is possible. Stent would have been a simple solution, but it didn't work in this case. So what could be the next simple? So what we had suggested was, we said, why remove the esophagus at all? This patient doesn't have any malignancy. She's a young, fit patient. Otherwise, there was a traumatic perforation. So what could be done? She said, why don't we try and then repair the tracheoesophageal fistula and put an interposition muscle graft? And then I'll come to these issues with my next case as well, as to why we discussed this. And this is just to give you some operative pictures. So to position you, this is the head of the patient, these are the legs of the patient, you're looking from the right side, and this is the tear in the esophagus. And can you see, I hope you can see, by my videos will show it more clearly, and this is the rent in the trachea, and you can see the stent. So this is the same operational view of the endoscopic image which you had a little bit earlier.
section.
be is that there will be two suture lines. Esophageal tear closure. So once that is done, we can now.
Esophagus. Okay, just take this out. So you see now the esophageal also. Yeah, both are seen very clearly. Yeah, stop.
And the trachea was closed. The issue is because both suture lines are next to each other and she has had a lot of soiling already, it is potential that they can get again infected and the sutures can break through, giving the same problem again. So what we decided was that we decided to put a flap. This is a sternocleidomastoid flap. So it was a tracheostomy incision, like a thyroid incision right in the middle of the neck, do the dissection, and the sternocleidomastoid is just sitting there. So you can disconnect the sternocleidomastoid either at its upper junction or lower junction depending upon where you want to put it. It's simple and it is very effective. Why? It will separate the two suture lines, and muscle is extremely good to protect suture lines in infected tissues. So this was the post-operatively, she was immediately extubated the next day. She had 2 weeks of parenteral and gastrojejunal feeding, and the gastrograph in swallow 2 weeks later. This is it. So we still left the stent. We still left the stent in order to have that additional protection in case there is a little bit of if the fistula again opens up because of infection in those suture lines. So just this is double protection. So what you can see is here you might think that there is compression onto the esophagus and the esophagus has narrowed, but if you then see the other, that is fine. So 2 weeks later she started having this is the X-ray pre-discharge. So we discharged this patient with the the stent in place. So we had long discussions, myself, Dr. Jayachandra, Dr. Abhijit and Dr. Praveen and Dr. Raghu. That is the team. So we had long discussions, and then we said, let us continue with the additional protection for the trachea. So gastrograph and swallow I showed, semi-solid and normal diet over the next 2 weeks, and then we sent her home. And this was, I think she was in both the hospitals put together, I think she was in the hospital for 2 months or a little over 2 months. And then 6 weeks later, this is now a week ago, she came back and we removed the tracheal stent. So it is a complex problem, and sometimes complex problems will have to be discussed as a team, and that is what I wanted to say. So it can be difficult to treat as patients are generally sick, but good results can be achieved by primary repair and interposition muscle flap. So again, going on to the same thing about a similar case, it's a 32-year-old female who presented with fever, cough, yellow colored sputum for 2 months, which was increasing on taking feeds, and a history of loss of weight and loss of appetite. I have to thank my colleague Dr. Swami at Care Hospital because both of us were involved with this patient. So she was managed conservatively, but symptoms worsened and absent breath sounds. And this is her X-ray. The right upper lobe completely destroyed. So what, again, this is a tracheo-esophageo-bronchial fistula. So not only is the trachea involved, there is a fistula. I will show you can you see that? So again, a complex problem. Will just stenting help? Probably not, because she now has a lung parenchyma which is involved as well. So in these situations, again, we will have to think about what could be the options available. Again, an esophagoscopy, you can see, it will show you. That's into the esophagus. You have to apologize. This was the only video I had of this patient, and you can now see. That's the esophagus, and that is a big hole. You're looking into the trachea. So there was a big tracheoesophageal fistula. That was then, there was the soiling, there was infection of the right upper lobe, and then the right upper lobe was completely destroyed, and there was a cavity. So even if you were to sort out the trachea or the esophagus, without sorting out the cavity, there will continue to be a space which is getting infected, and that will continue to create problems. So this was a fistulous opening. So what was that we thought we should do? See, she has to have two things addressed. The lung has to be addressed, the trachea and the esophagus have to be addressed as well. So we planned for an exploratory thoracotomy, a repair of the esophagio-bronchial fistula, and a lobectomy as well. So because unless you tackle all the issues, you leave any pending issues, they will come back to haunt you. That is what Jayachandra sir was also saying. If you have a problem with the trachea and you do a tracheal resection with leaving some problems, they will come back to haunt you. So again, we used a muscle flap. In places of infection wherein you are having suture lines, a muscle flap is extremely good to prevent infection and to facilitate quicker healing. And here what we did was we used a latissimus dorsi. This is a latissimus dorsi flap, and then this is a serratus anterior flap. Those who have watched thoracic surgery, getting these flaps is very easy. It takes time, but it is easy. So, and you have to have made that decision before, because if I do a routine thoracotomy, I will divide the latissimus dorsi. But if you are having a plan like this, you shouldn't divide the latissimus dorsi or the serratus anterior. You actually have to make sure that you are able to take it all down and then keep it ready as a muscle flap. So again, going through very clearly, again the same kind of interrupted sutures. That's the whole. I'll go through these very quickly. So we closed it, and then we did the lobectomy, and after doing the lobectomy, we then used this muscle flap to put it onto the suture line of where we closed the stump of the bronchus, and this is what had happened. So we got it a little bit wrong, not fully wrong. Everything inside was fine, but because we had extended the incision during surgery to get the latissimus dorsi, this area got devascularized. She developed a small ulcer, and in the next 4 to 6 weeks, even that here cleared. So planning, I think, is very important, and if you ask any surgeon, he wouldn't have done hundreds of these cases. Everybody will have a limited experience. So collectively, we have to do a plan which is safe. So report was, again, it was a chronic inflammation and fibrosis, granulation tissue. There was no evidence of malignancy, and post-operatively she did quite well. So these were an acquired fistulus. Acquired fistulus can be because of malignancy, or it could be post-traumatic, and sometimes you will never know the reason. It could be some infection which then corroded. I suspect she had a lung infection, and somehow it was the mediastinum was also involved, and that is what caused the tracheoesophageal fistula. And surgical results are good for these patients. I didn't want to talk much about tracheal stenosis. This is the only slide I have about tracheal stenosis, because when do we get involved? As I said, we get involved when interventional pulmonologists are not able to do anything, or there are multiple issues as to why they cannot do anything. But by and large, for these post-intubation or post-tracheostomy stenosis, I think interventional pulmonology is the excellent answer. And as I said, I have because thanks to Dr. Jayachandra sir, we have a big experience but very little surgical experience for tracheal resections, and I think that is the way to go forward really. So up to 5 centimeters of the trachea can easily be resected. That can be extended up to 7 to 8 centimeters also if required, and usually reserved for cases where other modalities fail. So I have spoken to about the kind of problems we will deal with about in these regions, and now what about these regions and these regions? So is endobronchial only endobronchial? Why I say that is a 61-year-old male presented with cough and expectorations associated with breathlessness. He was admitted 3 months prior to presentation with a similar complaint. He was empirically started on ATT, no change. So he was sent. Now if you saw, Jayachandra sir showed you a similar endobronchial picture. Again, very simple. So is this all? I think this is where getting the workup complete is important, because a huge mass sitting into the right main bronchus coming into the carina. So that is his X-ray. Yeah, any takers what the X-ray is showing and all that very quickly? The right lung is collapsed, the mediastinum has moved to the right, so whatever the reason, so and then I'll show you the CT scan. Now, what does the CT scan show? there is a mass. This is the endobronchial mass which you could see on the bronchoscopy, but you can also see that it is extending into the parenchyma, and see what it has done to the lung. The lung is all fibrosed and destroyed. So this is a chronic process. Whatever it is a chronic process. And the lung is destroyed. So is endobronchial just treatment endobronchially enough? Sometimes it might not be, because this lung will come back to haunt us whatever you do. It's a destroyed lung, and there is a mass peribronchially as well. Biopsy confirmed a typical carcinoid. So what to do in these patients? And again, a lot of discussions, and this was our point of discussion. Just taking this bit alone will not help in this case, because this lung will give you more trouble. So in these kind of cases, again, surgical intervention might be a better option than non-surgical intervention. And what we did, again, so you see that the lung is also involved. Lung parenchyma is involved. And what we had to do for this patient was a ventilation perfusion scan to see how much of the lung is actually getting ventilated and perfused, and that is to show that the perfusion was decreased, the ventilation was also decreased, meaning the blood supply is gone, the air supply is also gone to the lung, which means that this lung is destroyed. So taking just the endobronchial component might not really be enough, and his recurrent infection and cough could be because of the lung parenchymal element rather than just the endobronchial tumor element. So what did we do? This is just a couple of intraoperative pictures. This is a thoracotomy. You are looking into the thorax. This is the lung. This is the lung, and this is where the bronchus is, and I have opened the right main bronchus. So this is at the carinal level, and you can see that there is a big, huge tumor. So that's the lung, that's the tumor, and that's the bronchus. And you can see after removing it, we closed the main bronchi. So the right main bronchus was closed. Then this I just had it to show it to you that this is the tube which we have to put. We have to put a left-sided double lumen tube to isolate the right lung to enable us to do these kind of complex surgeries. And this is the lung removed. Can you appreciate that the lung is destroyed? And can you see that there is a parenchymal component of the endobronchial mass as well? Typical carcinoid, but they sometimes come with in this situation. So just dealing with endobronchially might not be sufficient. That is what my point is. So you might have to remove more. So the damaged lung is removed, and he is doing extremely well. He's now, I think, 8 years that I have been following up, and he doesn't have any more problems. So again, so I spoke to you about what some of the things which we do here, some of the things which we do here, and is there anywhere here that as surgeons we get involved? And I think, where do we come into the foreign bodies? Foreign body removals, first and foremost, the pulmonologist will deal with it. Most of the times there are children, and then there's little peanuts or something which can be perfectly easily, or I'm not saying easily, but they can be taken out by the pulmonologist. So where do the surgeons come into these kind of images? So again, a little boy, and he inhaled something, it was noticed, so it was taken to the nearest doctor. The nearest doctor saw the x-ray, not mine, sent it to a pulmonologist. The pulmonologist saw and said, okay, let us take the patient to the theater. So it was taken to the theater. They saw something, they just couldn't hold anything. They could see something, but they were just not able to hold anything. So then they were sent to another pulmonologist who tried a rigid bronchoscopy. The rigid bronchoscopy also, they couldn't hold it. They could see something, but they couldn't hold it. And every time they did, it went a little bit further in, but not out. So that is the nature of some of the foreign bodies. So what did we have to do? I'll show you the foreign body first. This is what it is. It is a little bead. It is a little plastic bead. And if you see the way it is, doesn't matter how you try to grasp it, it will slip. It will slip. And each time you grasp it, it will go a little bit further in and not out. So these are the patient. By the time he came to us, we realized, we again did a bronchoscopy, but explaining to the patient that the patient might have need surgery as well. Did the bronchoscopy, could find it, but we realized that it has already gone much distally into the bronchi. So we said no other option other than to do a bronchotomy. Bronchotomy is a thoracotomy, and then you open the bronchus surgically to deliver the foreign body. And this is this is the image, this is the lung. I'll have a better image, and then you can see that the foreign body is sitting there. So these are the times when we have to get involved surgically. Again, another thing. Anybody knows what this is? Yeah? Yeah. A 14-year-old girl who came to Century Hospital, this is now a year ago, yeah, and this is, she puts a scarf, and this is the pin which goes to the scarf. And what she tells me is, everybody in the school has this. They put it in the mouth, and then they adjust it, and then take it out from the mouth and put it back here. That's what she said. Everybody does that, she said. And unfortunately, on that particular occasion, she had a cough. So she breathed in before she coughed out, and this went in. The problem, I don't have that X-ray which when she came pre-procedural, they tried everything, but this is big. This is this much, and again the same problem. It keeps going more and more distally, and holding on to it by any instruments is very difficult. So we tried. We explained it again. Took her to theater. Again saw it in endobronchoscopy. I realized I couldn't do anything there. It had gone into the basal segments of the right lower lobe, and we said we will try it thoracoscopically. I put in the camera, couldn't see anything. We're just seeing normal lung because it is not come up to the surface level yet. So in these patients, all we will have to do is again.
You can. Okay. Incooperative mosquito dewormer. Give me a mosquito. Yeah. Yeah. I'm just trying to see if I can hold it. Okay. Can you see that it is coming out? Bloody hell. So
these are big treatments for a small problem, but sometimes they have to be done because there is no other way. So what we have to do is we do.
Yeah, just let him take one. Yeah. Anji? Yeah, that's fine.
Some Teflon pledgets. It doesn't take too much time, but it is a big incision. She will have a small scar for the rest of her life. But these are issues where surgeons will have to get involved if simple measures fail. So I wanted to talk about these, and then I wanted to talk about slightly something else. When we say airways, mediastinum also becomes extremely important for us because extrinsic pathology on the trachea can cause big problems for the airway protection and airways, but the reason is outside the trachea. So mediastinal masses, these are the typical type of patients which we have to deal with, and we have a lot of experience with mediastinal masses. So these are the kind of mediastinal masses which different types. I have about 3 quick patients which I wanted to show. These can press on, and then what we have to do is again a thoracotomy. This is a thoracotomy, and through the thoracotomy, through the mediastinum, that is the mass, and we will have to.
This is the lung, and this is the margin. This is the phrenic. This is the phrenic, and this is the thymic remnant. This is where we have put a tie onto the thymus. And this is the pericardium. You can see the pericardium, and from which it has been dissected out. Okay, right. Thank you. So phrenic, sir. Thank you.
Because they are close to the great vessels, taking these out can be a challenge. Sometimes possible thoracoscopically, sometimes not possible thoracoscopically. If it is not possible thoracoscopically, never hesitate. Convert it into an open procedure, because safe operation is what is more important than cosmetic operation. So this was another case. I just wanted to quickly show it to you. Probably it doesn't come into the realm of the mediastinum itself, but there are lot of times wherein you see these kind of lesions and then you think what they are. This patient came with chest pain. he had a CT guided biopsy, only fibrous tissue. They were again not sure, worried about whether it was a malignancy, and again these are the kind of things which you will see, and they sent it to us. Now these kind of patients, a thoracoscopy will probably be extremely good, because it will not only help in the diagnosis, but sometimes it can help in therapeutic procedures as well. Any guesses as what it might be? Mesothelioma? Somebody said, well, fair comment. It was a thought process. It could be. Yeah, and then mesothelioma histopathologists also will never be able to give an answer on small biopsies. They will need big biopsies or complete excision biopsies for these kind of things. That is what I actually also was thinking, what could this be? So these are the situations wherein a thoracoscopy will be helpful. Why? Because you put in a camera and then you see everything in front of you. This is not a mesothelioma. This is not even attached to the chest wall. This is attached to the lung. This is a collapsed lung. To orientate you, you are inside the chest cavity. These are the ribs. You can see the ribs. So that is a pleural space, and this is a mass which is attached to the lung. Now it becomes simple. All you have to do is put a thoracoscopic stapler. You just staple it out, and then we take it out. So that is the mass that is attached to a bit of the lung. So you have stapled it out, taken that and the lung mass out. We did one yesterday. Jayachandra sir and myself, we were involved with a pneumothorax secondary to a small bulla. We did a medical thoracoscopy. Sir already knew that there will be something, so he said, Hemant, you be around. So I was there. Sir said, there is a bulla. Why? What shall we do? I just said, let us staple it out and take it out. So a medical thoracoscopy, and in medical thoracoscopy we converted it into a therapeutic procedure as well. So I think that is the reason why I think a teamwork is extremely important. Another similar case, this is a patient who had a seminoma, had chemotherapy, and after chemotherapy you can see that there is a mediastinal mass. Now had a PET scan, mild to moderate uptake on PET scan, which means that it could be residual cancer or maybe not. So these are the kind of patients which we get involved when we are involved offering a full range of thoracic surgical services. So again, to orientate you, this is the head of the patient. This is a sternotomy done. Now this is an approach wherein we go from the front rather than from the side, and you can see that the mass is attached to the pericardium. So we have opened the pericardium. You can start to see the heart itself. So when it is attached to the pericardium, it is sometimes actually easier to open the pericardium and safely remove the whole mass. So you can now see that the whole of the pericardium has been taken out along with the mass, and that is the innominate vein, that is the aorta, that is the right ventricular outflow tract. So it helps to take the whole mass. Why is this important? In these patients, now you can just see the phrenic as well. We had to remove the phrenic from the mass and protect the phrenic nerve. Otherwise, they will have diaphragmatic palsy. So this was the residual mass. We sent it off for the histology, and histology confirmed that it was not malignancy. It was just post-chemotherapy changes. So these are the kind of cases we get involved. So trachea and mediastinum to a surgeon is a kind of a one group of pathologies. And these are the challenging area, as the pathologies have a very wide variety. They can come from the oncologists, they can come from the pulmonologists, they can come from the physicians, they can come from colleague surgeons as well. A team approach is essential, and we need to explore technologies and newer treatment modalities first before we start moving to traditional treatments. Thank you. Abhijit, I think is just out. So now, sir, shall we take the questions a little now? Because the next topic is the ECMO and the interstitial lung diseases, which Dr. Paramjyoti sir said he will talk. Airways, shall we take? So a 5-minute question answer session or anything about the airways. Can we have the lights on? Thank you, sir. Thank you very much, sir.
I think it's an open session. Any questions on central airway obstruction, medical, IP, surgery, whatever?
I had a question to Dr. Lata sir. It was about one of the patients, I briefly spoke to her about it. The post-pneumonectomy, I'm just interested for those of you, she presented one of the case wherein a post-pneumonectomy patient, almost 40 years post-pneumonectomy patient came with tracheomalacia and then a narrowed thing. I asked her one question, and that was whether the mediastinum has shifted and why she thinks that 40 years later also these people should have a tracheal problem.
There definitely was a shift of the mediastinum, and we thought that is the reason. And nowhere in the literature it is mentioned that a patient with the tracheostomy has developed it 40 years later. He was symptomatic only for 3 years, but the usual course of events is usually after 1 year there is a twist of the mediastinum. So for him it was 40 years and he survived till 83 years.
Yes, it can be reinforced with a muscle flap. Yeah. After reinforcing. No, when. Yes, sir. Yes, sir. Yeah. It's a very important question, and this is where we will have to always say why God does something the way He does. He probably has reasons. He has given the surgeons muscles with supply from one end. If you take the latissimus dorsi, the blood supply comes from here. So if you separate it from here as a flap, it will still have its blood supply. The serratus anterior comes from this way, and the blood supply also comes this way. So if you were to detach it here, lift it as a flap, which is still attached here, meaning its vascular supply is still there. So when we detach serratus anterior or latissimus dorsi, we are doing this through the rib cage. We put it in like this. So it is still connected to its vascular supply. And when it comes to sternocleidomastoid, the same thing. Sternocleidomastoid is one beautiful muscle because it has blood supply from the top and the bottom as well. So if you disconnect it from the top, it takes blood supply from the bottom. If you disconnect it at the bottom, it gets blood supply from the top. So it becomes easy. Absolutely. If it's the upper trachea, sternocleidomastoid is here. But if you are going into the chest, a serratus anterior or latissimus dorsi. My colleague Dr. Abhijit Dashetwar has much more experience with muscle flaps than I have. So when I'm doing a thoracic surgery and then both of us operate together, and if I think that a muscle flap is required, he starts the operation, gets the flap ready, and then I do it.
Anything we can do to avoid PITS, that post-intubation tracheal stenosis? Is there anything you can really do?
Madam, they will be better. I get into the picture only after it happens, never before.
How careful we should be?
No. See, the competence in maintaining a ventilator, okay, is not matched by the care taken for the endotracheal tube. This is the biggest problem. Most times, a standard endotracheal tube is used to intubate, irrespective of the size of the trachea. Now, what you need to have is an appropriate size of the endotracheal tube with a minimal amount of high volume, low pressure cuff on the endotracheal tube. And this needs to be deflated at periodic intervals so that there is no pressure necrosis of the mucosa of the trachea. That is where the damage occurs. Now, the problem with most of the management of ventilatory cases is they put in a endotracheal tube, inflate the bulb, until the patient comes off the ventilator, the bulb is never deflated, never shifted, it is left like that. So as a result, there's a lot of mucosal necrosis of the entire mucosa, leading to a damage and subsequently a post-intubation tracheal stenosis. This used to be much more common with red rubber endotracheal tubes, which are high pressure, low volume cuffs, where you used to have a much higher incidence of that. I have seen people having a PITS after 2 days of intubation. That is ridiculous. It shouldn't be happening at all. But it does happen. That is because you have overinflated the bulb, you have used a smaller tube, and to maintain the integrity, you have really pushed in more air than what is required to maintain the air leak from the trachea. So you need to, supposing it's an adult male, probably will comfortably take a 9.5, but wherever you see it is a 7.5 with a this thing bulb which is inflated, overinflated to maintain the integrity. So these are the things which you need to take care. Your care of the ventilation should also include care of the endotracheal tube, which is not being done.
The mini tracheostomy that is being done nowadays, you have to push it through with pressure, and the moment you do it, there is a chance that you damage the posterior end of the trachea. That also is the reason for the increasing number of tracheostomy
No,
problems
percutaneous tracheostomy, this is the other thing. You put in a needle, then you put in all that. I've seen multiple puncture marks on the posterior wall of the trachea. And the moment you try to use pressure and do that, you are asking for trouble. Somewhere, if you lose control over the pressure, you're going to puncture it through and through the trachea. And the case which Hemant had presented, that's what had happened. An ENT person had done the tracheostomy. I mean, there's no doubt about it. But immediately after that, when I saw it, the moment you remove the tracheostomy tube, there's a huge tear in the posterior wall. And we had to use a large self-expanding metallic stent because you want to have no leak from there. But the thing is, the bigger the size, the more it stretches the fistula also. That's another problem. So you need to find a right balance which will occlude the thing, at the same time not tear the fistula any further. These are the kind of issues that you will face when you deal with this kind of problems. Every day, at least once, or every 8 hours, you deflate it for about 5 to 10, 30 seconds to 45 seconds before you inflate it. Otherwise, you shift the tube a little bit, don't let it be in the same position, shift it 2 centimeters down or pull it out 2 centimeters before you inflate it again. Alright? But the only thing is, make sure that the tube is deflated and you give enough time for the mucosa to retain its vascularity again.
Actually, it depends upon the indication for which the patient is intubated. If the patient is intubated for airway protection only and to prevent aspirations, you keep deflating it, there is no purpose. It doesn't serve any purpose, especially for neurological patients. In those cases, you can't deflate for long periods. And patients who are on high pressures, high PEEP, or requiring high FiO2, there is no way you can keep deflating it in between. So the idea is you have to have, as sir said, the tube should be of ideal size and the pressure should not be there, so that you can prevent the pressure necrosis. Deflating intermittently for a neurological patient or a patient with high PEEP is really, it cannot be done. There, if the indication is only for airway protection, then there is no other reason why you cannot deflate intermittently to prevent aspirations. And in that situation, we have tracheostomy tubes which have subglottic suctioning, where you can have the suctioning from that site.
The only way I would answer that question is probably not, because if you can get a stent in to hold it up, that's a simpler solution. Yeah? The only situations wherein we have done a couple of repairs are in babies who have tracheomalacia and a collapsing trachea. So what we can do is that we can stitch the trachea to the posterior mediastinum, to the behind the sternum. That is some procedure which I have done only twice in the last 20 years. So not routine. You have simpler solutions, and a stent is probably a much simpler, easier and better answer actually. So we can certainly.
No, but having said that, for the case that I showed you, like an EDAC and all that, putting a stent really is not an option. See, putting a stent is the easiest of things that you can do. whether it's a Y stent or a SEMS or whatever it is, very easy. You put it in and you're very happy that you kept the trachea open, lumen is okay. But the number of problems you're going to have in the long term because of that, it becomes such a nuisance. You're going to, solve one problem, but, invite so many others to come in because of that. So probably in this kind of cases, probably you can think one is a BiPAP, as she had mentioned, BiPAP or a CPAP, which is extremely good. Then pursed lip breathing is another thing. If you can train them, that probably by giving enough back pressure, it will solve the problem to a certain extent. But there's no clear-cut this thing, because the entire tracheobronchomalacia is going to extend right from the upper trachea down into both the main bronchi. So it's very, very difficult to go on and do that. So even if you put a stent, you're going to put it's going to take care of the left and the right main bronchi. But again, when you go into the segmental, they're also going to collapse. So stent is not an answer. Surgical correction also, for the same reasons, may not be an answer. But other measures like this may be helpful. No, we don't have stents for that age group. But in desperate situations, some of the vascular stents are used in the tracheobronchial tree as a short-term measure. But really on a long-term basis, they do not have the thing. Anything in the adolescent, probably about 8-10 years, yes, you have stents available. Younger than that, no, I don't think we have stents tailor-made for that age group. So I think we'll get on with the next part of the thing. We have a talk by Dr. Praveen. He's a CT surgeon with talents which extend a little further. He looks after ECMO patients here, and I don't know much of ECMO, but Praveen has been teaching me a little bit, and we've already managed one case successfully, if I should add, come out of the ECMO for a H1N1 infection with ARDS and other things. We are still going on, we are learning. At least for me, it's a very new modality. I've been seeing cases in KIMS and other places, but personally I have not handled any of these things, but I think I'm sure Praveen can take us through the entire this thing.
Good afternoon and welcome to Century Hospitals. Thanks for the introduction, Dr. Jayachandra Garu. I hope all of you guys have still got lots of sugars left in you to have a concentration here. Moving away from the airway management, both medically, surgically and medically. And before I go on, I would like to kudos to Dr. Jayachandra. Probably very soon he will take all the surgeons away from their jobs. The amount of bronchoscopic management of luminal lesions, I think it's quite a new thing, and I'm very happy that they are being handled by Dr. Jayachandra, and we are happy to be a part of his team as a team thoracic surgery and pulmonology. ECMO wasn't heard of until Jayalalitha popped off. Right. We have been doing ECMO for the last 5-6 years now. I mean, I have been trained in UK on ECMO. I was a fellow in transplant surgery and mechanical heart failure services or surgical heart failure services, where we normally deal with ECMOs as in we know arterial, but again for respiratory diseases as well, there's lots of involvement of ECMO. And as I've said, ECMO took a center stage when Jayalalitha had the problems, and whole of India was quite wary of it, that there's something called ECMO. Nowadays, patients come to us and ask, does this hospital have ECMO? Earlier it used to be the ventilator. I think now patients don't want to die. They just want to know whether they have got ECMO so that they can be put on. Because the people have realized that patients can be made alive with both their heart and lung being supported by ECMO. I'm just going to go on, sir. I'm just not stopping here. I'm moving on. Right. What is ECMO? It's extracorporeal membrane oxygenation. When I say extracorporeal, corpus is body, extra is outside the body. Membrane oxygenation, that's lung, oxygenation outside the body. So what are the types of ECMO we have? We have something called veno-arterial, which supports both the heart and lungs. The job done by your heart and lungs is done by this machine, which has got a heart-like pump outside the body and a lung-like membrane outside the body. So it does the job of both your heart and lungs. Essentially, a patient can be kept alive on a veno-arterial ECMO when both his heart and lungs are not working. Totally failed. I'm telling you, it's a totally failed. If you look back into the CPR protocols, in the Western context, the protocols are now eCPR. That is, ECMO is mandatory as a part of the casualty or the emergency setup, where patients coming with acute coronary syndromes, crash and burn patients, where they put in ECMO straight away. Don't do CPR. Put them on ECMO. CPR is like oblivion now. Then we have something called veno-venous ECMO, where the patient's native cardiac output is being maintained, the heart is intact, doing well, good cardiac output, only the lungs have been messed up because of the parenchymal disease. There is no oxygenation happening, so you will have to oxygen the body, because hypoxemia is a dreadful complication which can cause arrest any moment because it's not competent with the life. And then you have got something called arteriovenous, where there is no pump, but it is just a membrane where we utilize the patient's native blood pressure, and it is essentially used in patients with COPD to drive out carbon dioxide. What are the indications for ECMO? Essentially hypoxic respiratory failure due to any cause. We call it ARDS of any cause, H1N1, bronchial pneumonia, whatever the cause be it, toxic injuries, smoke inhalation and all this stuff can be considered the risk of, when the risk of mortality is more than 50% or greater, and is indicated when the risk of 80% greater. 50% mortality, when do you say it is 50% mortality of an individual? When the PaO2 to FiO2 ratio is less than 150, on an FiO2 of 90, and a Murray score of 2 to 3. Murray score is basically from the anesthetics point of view, where they take into consideration the PEEP and the airway pressures. And also a PaC2 of more than 80 mm of mercury, or an end inspiratory particle pressure of more than 30 centimeters is an indication for ECMO in patients with ARDS. So what are the contraindications? PEEP levels of more than 30 centimeters of water for more than 7 days. So unlikely that this lung is going to recover. FiO2 of more than 80% for more than 7 days. Limited vascular access. Terminal cancer or severe brain injury that cannot be reversed are not candidates for ECMO. And those patients who cannot receive anticoagulation must be excluded. What are the armamentarium for ECMO? We have cannula, then we have integrated centrifugal pump and oxygenators, ECMO console, and a heater cooler. So these are the cannulas. These are the arterial cannulas. If you can see, the company guys pretty well understand the surgeon's brain is out when they are in an emergency, so they have coded it red. So they are the arterial cannulas, which are for the returns cannula. And the blue cannula is the venous cannula, which are used for venous drainage. This is a wonderful cannula called Avalon or Oregon cannula, which does the job of both arterial and venous drainage, arterial returns. If you can see, the blue thing drains blood from the heart, and the red thing, blood goes back into the heart. So this is beautiful cannulas, but which are very costly, 1.56 lakhs per each cannula. Probably given the nature of the cost of the ECMO initiation, I think we should be starting to use them. And in fact, we have got a couple of cannulas on board now available. I think we are the only hospital in Hyderabad who can boast of having these cannulas now. This is the machine, sir. If you can look at, this is the pump, which I'm talking of. This is the heart outside the body. This is the lung outside the body. This is made of silicone membrane, and this is a long-term oxygenator. So if you understand anything about cardiopulmonary bypass machine, normally we use an oxygenator in the theaters, and we have a big heart-lung machine which has got multiple pump heads. But this is a centrifugal pump head which takes out blood from the patient, puts it into the oxygenator, and goes back to the patient. That's how the circuit looks. So for anybody problems with the lungs, I'm not discussing here with the heart, I'm only discussing only with the problems pertaining to the lungs. So blood is drained. I've shown you two kinds of cannulas. One cannula or a single stage single cannulas, arterial and venous. So here, this is where how we use. The blood is drained from the groin to the femoral vein, and the pump sucks out blood. It's a centrifugal pump head. It sucks blood and then pushes through the oxygenator at a pressure. And the oxygenator gets oxygen from outside with oxygen lines, gets oxygenated, and goes back to the patient. Why are we doing this? We have realized that lungs are not functioning. They are not able to oxygenate, they are not able to ventilate or wash away the carbon dioxide. So we are trying to set up oxygenation and ventilation outside the body. So this is what it does. So blood is drained to the centrifugal pump, pumped to the oxygenator, gets oxygenated, goes back into the patient. A fully oxygen-rich blood into the patient now, so that the hypoxia is avoided. This is the double lumen cannula which I was talking of earlier. You don't need to put any cannula into the groin. This is how the cannula goes into your interjugular vein. It has got 3 ports. One sits into the IVC, one sits at the mouth of the SVC, and one into the body of the right atrium. So the unoxygenated blood is sucked from the IVC end, from the superior vena cava end, taken back to the pump, oxygenated, comes back to the patient into the right atrium, body of the atrium, and the blood goes straight away into the tricuspid valve, into the right ventricle. So essentially you are avoiding 2 cuts, one in the neck and one in the groin, very comfortable for patients who are obese, and especially in an emergency. We don't have to wait for the groin to be exposed, to expose the femoral veins. At the time of crash, when the patients are collapsing, the blood pressure is right down to 40. It's very hard to find a pulse, or even hard to find a vein as well. So most of the times our anesthetists are very friendly to put in a guide wire here, and then it goes smooth, slides in smoothly. So this is what it's the closer look, if you can. See, as I've said, this is the returns orifice. So blood is sucked out from here and here. This goes the right atrium, goes back to the pump, and oxygenator comes back here into the right atrium, into the right ventricle, to be pumped into the body. So we had a couple of case studies recently. This is a 30-year-old, 24 weeks pregnant patient transferred from one of the obstetric hospitals in the city. She went into the hospital with lower respiratory tract infection on 25th of Jan. She had some antibiotics started. They noticed a couple of patchiness in the bases, but in spite of the antibiotics, she continued to become breathless. Chest X-ray was getting worsening, and then she was transferred to Century Hospitals by our OPSMED team, which is looking after the high-end obstetric cases. So basically, she was transferred to us on the 29th of 1st, and she was diagnosed as H1N1. So in spite of the best ventilatory measures, she had all the types of ventilatory measures, prone, ventilation, what all you call. Everything was done, but without much help. Hypoxia, hypercarbia, low pH. So on a Friday, typically all these things happen on a Friday evening when you want to go home to spend time with your family. So I had a call. I was in the office, and then they said the patient is crashing. Hypoxia, pressures were right down to 40, 50s. So I came rushing upstairs, and then we resuscitated her. And thanks to my anesthetic colleagues, Dr. Harshal and Dr. Sunil Pandya and team, which were very quick, and thanks to them for bearing all my eccentricities and shouting. Because at that point of time, the surgeons are out of their minds, but we just had to CPR her. We had return of circulation, but oxygenation was not happening much, so I had to initiate an emergency ECMO, which was veno-venous. I mean, it was pretty hard, because prior to this, I was talking to the family about the outcomes being 80 to 20, and now when an emergency ECMO is being initiated, I gave them a mortality rates of 50%. I said it's very hard to know whether this lady would come out or not, because she has crashed. Her downtime was about 3 minutes, Harshal, close to 3 minutes. So 3 minutes, hypoxic brain injury, I don't know what is going to be the outcome. So I had to initiate for only one reason. She's a young mother, she has a daughter who is 3 years old, she's 30 years, should give a chance. So that is where the madness comes in. So I discussed with the family, ECMO was discussed, and then we initiated it on the 3rd of the 2nd. This lady, she's a fighter. I don't know how she's sustaining and moving on, but she's a fighter. She progressed steadily over the few weeks. And then, as you know, I mean, the patients who are on ECMO, they are anticoagulated. They are on heparin infusion to keep the blood anticoagulated so that the blood keeps running in the circuit without clotting. If a clot forms on the membrane oxygenator, that lung doesn't work. And if there's a clot somewhere in the cannulas, it can throw up showers anywhere else. So ideally, the blood should be anticoagulated, thinned out with an ACT, that is activated clotting times of 160 to 180 seconds. And we are very particular about these ACT times, which myself and Dr. Harshal and all the anesthetic teams, we are constantly on the watch trying to tweak it this way and that way so that it stays at 160 to 180, so that we don't want the risks of bleeding, which can be a catastrophe if it bleeds into the brain, or if it bleeds to the chest, that's fine. Abdomen, it's okay, we can open, but brain, the game is over. That's the end of the patient. So we have to just give up. So we are very particular about our ACTs. So this patient, she continued to progress very well, but unfortunately, most of the nursing staff, they tend to do the suctionings inside the trachea with the ET tube or the tracheostomy tubes. We had some ooze into her left lung. I think that was shown by Dr. Jayachandra earlier, the X-ray and also the bronchoscopic views, where the left mouth of the left bronchus was totally occluded with a clot. We tried suctioning it on a couple of occasions to recruit this left lung, but every time we take out the clot, it refills and the lung becomes opacified. So at one point of time, there were discussions of taking her back to cath lab, do a angiogram, bronchial artery embolization, but I said she's 30, she can survive on one lung. Let's get her out of ECMO first. I don't want to take her down to cath lab. It was a common consensus. We said, let's bring her out with one lung. Most of the patients are there with one lung, so why not her? So we decided life is more important than the lung, so we just moved on, and she has progressed very well. The lungs, the left lung, the upper lobe is aerating now. So we moved on, and as I've said, we were making a plan to decannulate her on last Monday. On Sunday night, she throws a challenge to us. She decannulated herself from the neck. You won't believe, I was about to have a drink with my father-in-law. My other colleague, Dr. Rupak, who was in the hospital, gives me a call stating that you need to get out of the house first. I said, what? And I said, look, the patient is bleeding. I said, what? Then I just had to, it took me 12 minutes from High-Tech City to Century Hospital. Just 12 minutes. I'm saying, I might be getting a ticket from the police very soon, but I don't know. But life was more important. I can always give my points back to them. Came here. By this time, I was shouting on my phone in the car, telling them what to do, switch off the pump, put pressure on the neck, give volume. You won't believe, she received 30 units of blood and blood products in just 4 hours of time. 3-0. And that's her, alive, ticking, on tracheostomy, off ECMO, and she is smiling. Still a long way to go. Another probably 2 to 3 weeks before we can allow her to come off the tracheostomy. And this morning the lung looks much better. We just had an X-ray, Dr. Jayachandra garu. The left upper lobe shows aeration. So we're planning for a CT scan tomorrow to see how far this clot is in the left bronchus. And if there is anything, probably can we help by a rigid bronchoscopy and then just extract it out so that we can recruit this lung. Even otherwise, I'm not going to do anything to her right now. We're going to send her home, bring her back in a couple of weeks' time or couple of months, hopeful that this lung will resolve or the clot can be extracted at that point of time. Life is more precious, lung not. Probably she can survive on one lung. And in fact, I forgot to tell you, because of the hypoxia to the placenta, she lost her baby inside the womb. She had an IUD. We had to wait on for the expulsion because I couldn't initiate ECMO because of the anticoagulation. The uterus is raw area. It's a surgeon's nightmare. I'm telling you, I haven't spent any time at my home for the last 4 weeks. I have been running into the hospital left and right. So moving on to the next one, we got another patient here who is giving me nightmares again. I've been into the hospital since 3 o'clock this morning. All my colleagues are having fun, like Praveen spends his time in the hospital. So this is another 52 male patient of Dr. Jayachandra who walked into the hospital breathless, SATs at 67%. Is that right, Dr. Jayachandra? 67, gasping, panting, and we put him on to the hospital with all the measures, conventional measures, and then he was intubated. Subsequent to that, he's again the same scenario, total whiteout on both the lungs, pH, low pH, PaCO2 is climbing up, no hypoxia, patient restless. So we just decided to move on to ECMO, again VV ECMO. So at this point of time, it's day 10 today. He's cruising nicely. There are some issues up and down, but overall we are trying to keep him under control. So I'll just show you a video. You have seen the sketches earlier, the photographs, but this is actual video which will help you in that's the ECMO pump in action as such. The patient is currently with us. So careful selection of ECMO candidates is critical because of potential complications and substantial costs. It's quite costly, but for life, money shouldn't matter if money is not a problem, because that is the only way we can bail out them, because in spite of all the ventilatory measures, in spite of recruiting both lungs, high PEEPs, FiO2s, if the patients don't make it, they would die because of hypoxic cardiac arrest, or if they come out, they will have hypoxic brain injury, which is incompatible with life. We don't want a vegetative state, and even kidneys can take a knock. So ECMO is useful in single organ failures, or at the max multiple, two organ failure, heart and lung, or heart alone, or lungs alone. And the associated high mortality, a perception of ECMO being an inefficient use of scarce resources. It's being said every time that when we pop up the question of the usage of ECMO, people would ask me, how much does it cost? Yes, it does cost, but for a life, I think if money is not scarcity, please utilize it. This is one mechanism to bail out patients, young patients. If you could see the 30-year-old girl, a woman, mother of a 3-year-old, you can understand the distraught of the young girl losing out on her mother. To be honest, I didn't have any hopes for this lady to come out. But in the first instance, I thought she would have a brain injury. In the second instance, her blood pressures were about 30 or 40, and as I've said, my nursing staff were like holding on to her, pressurizing her. She was sort of conscious, trying to wriggle out, and it was a nightmare. But ultimately, we had my friends have been saying that I'm playing chess with God, trying to, in the game of death, trying to win who wins. So I'm trying my best, so let's see. So I don't mind if he curses me, but at the end of the day, it's a life. I'm happy to take this forward. Communication and teamwork, that is a major part, because I tell my anesthetists, my nursing staff, talk. Even if you have done some stupid thing, please let me know. This morning I asked them to give 40 milligrams of Lasix. They gave 20 and then say, we thought it is excess. How can you think that it is excess when I have said, I need to be told that you have given only 20. So communication is very important, very important. No matter how you communicate, you got to communicate. Unless until communication happens, the outcome would be fatal. So for a good outcome, communication and teamwork are very important. Thank you. Thanks, Dr. Jayachandra Garu.
It is a challenge. Praveen makes it all a little bit friendly and then jokey, but what he does is very good work. We are glad to have him as a part of the cardiothoracic team here. He has a special interest in heart transplantation, in left ventricular assist devices, and ECMOs. So you can see when he is around, things will go wrong. That's you can see that. Yeah.
Before I go away, Dr. Hemant, myself, and Dr. Abhijit, we're all known to each other for a good number of years. And as a team, we don't have any airs. I yell at Hemant, he yells at me, I yell at Abhijit, and we don't have any airs as cardiac surgeons are always said that they are cranky, eccentric, lunatics. We are, but as a team, we are not. Thank you.
Part of the testing program. Let me invite Dr. Paramjyoti, Professor NIMS, Pulmonology, to talk about interstitial lung disease, another interesting topic.
Good afternoon, everybody. Am I audible? Yeah. Thank you, sir, for inviting me. Thank you, Hemant, for inviting me here to talk on interstitial. When Hemant called me, said you're going to talk on interstitial lung disease. I said it's a big topic, it's a dry topic. I said, okay, not interstitial lung disease, I'll put it as IPAF, because the term IPAF is a new term. There's not much of data available internationally or nationally, so I have very little to talk, so my talk is going to be very short. So that's why I've chosen this topic, IPAF. I don't know whether the slides will come out well, because our residents have designed it in my computer. How to change it? You have a pointer here? Yeah. Yeah. So, what do we mean by interstitial lung diseases? Interstitial lung diseases or diffuse parenchymal lung diseases, or a group of diseases which are very different phenotypically. So it's a collection of lung diseases which though they're different, but yet share certain common features. That is, they share certain common clinical presentations, they share certain common pathologies, they share certain common physiologies, and radiology wise they share certain common features. That's why all these are put together and clubbed in under one term called interstitial lung diseases. And interstitial lung diseases are because the pathology that is there is usually inflammation or fibrosis that is confined to interstitium, and not necessarily interstitium. We'll come to that bit later. So we have a group of diseases varying from idiopathic to known causes. Again, in the known causes, you have definite etiologies or unknown etiologies again. But a major group of interstitial lung diseases that we deal in our institute, because we have a very strong rheumatology department. So connective tissue diseases are major interstitial lung diseases. CTD, ILDs are very common in our institute. ILD, again, as I told you, it is called interstitial because the pathology begins in the interstitium. ILD is a misnomer because the pathology is not just confined to the interstitium, but it all spreads into the alveolus, to the small airways, and there is a vasculopathy as well. So ILD is not just limited to interstitium. Now, what is interstitium? What is pulmonary interstitium? I am talking basics, please bear with me. Yeah, some of those the stalwarts here, please bear with me. So pulmonary interstitium is a loose areolar tissue that is sandwiched between the epithelium and the endothelial basement membrane. So it's all across the lung parenchyma. You have a axial interstitium that is around the bronchovascular bundles. You have the subpleural interstitium that is along the pleura, and you have acinar or parenchymal interstitium. So the yellow ones are the subpleural, the blue ones would be the acinar, and then you have the axial. You have pointer here. Yeah. So this would be the axial interstitium, this would be the parenchymal or acinar interstitium, this is the subpleural interstitium. Yes. So the various terminologies were used to describe these conditions, starting from cirrhosis of lung to acute Harmon-Rich syndrome to chronic Harmon-Rich syndrome to widespread pulmonary fibrosis. These are various terms that were used, and finally it was in 1969 that Lebo and Carrington tried to classify these interstitial lung disease. Now, when I am concentrating more on idiopathic interstitial lung disease, I am not talking of all the entire interstitial lung diseases, but Lebo and Carrington, they tried to classify idiopathic interstitial lung diseases into various types, and then the classification evolved over years, and now we have this joint statement by ATS and ERS in 2001 based on histologic types and based on clinical radiological, they have classified idiopathic interstitial pneumonias, and then again in 2003 they have included some terminology, some interstitial lung disease, and there was some clarification as to what is an IPF, what is an NSIP, and some unclassifiable interstitial lung diseases have been included in the classification of idiopathic interstitial lung disease. There we are. This is the diffuse parenchymal lung disease, we call it, or interstitial lung diseases, where you have known causes. Very many drugs can cause interstitial lung diseases. There are many associations with interstitial lung diseases. You have connective tissue. These are all some known causes which can cause interstitial lung diseases. And you have granulomatous interstitial lung diseases like sarcoidosis with unknown etiology, or you could have known etiologies as well, and some forms of DPLD which are common in females like lymphangioliomyomatosis or Langerhans and histiocyte. All those things, some interstitial lung diseases are classified this way, but most important thing that I will be stressing on today would be idiopathic interstitial pneumonias. These are broadly divided into IPF and non-IPF interstitial pneumonias, because the pathology is little different, treatment is different, prognosis is different between these two groups. So IPF needs to be separated from non-IPF idiopathic interstitial pneumonias. And in the non-IPF idiopathic interstitial pneumonias, you have various types of things that are described. DIP and RBILD, this is more common in smokers. Acute interstitial pneumonia is what is called acute Hammerich syndrome, and organizing pneumonia, LIP, pleuroparenchymal fibrosis, NSIP. This again is removed now, provisional is removed, and it is called as NSIP, no more provisional. It is a definite entity as such. But there is, what I'm going to talk of IPF is not mentioned here. In 2013, it's not mentioned. So IPF is a new term. So the classification further goes depending on the clinical behavior. You have a reversible and self-limited ILDs, RBILD, that is respiratory bronchiolitis interstitial lung disease seen in smokers. It is reversible and self-limited because once this is seen in smokers, so if patient stops smoking, the disease disappears. Then some of them are non-reversible, or some of them are progressive, like that's why we say idiopathic interstitial pneumonias have to be IPF and non-IPF idiopathic, because IPF is a relently progressive disease and it is an irreversible process. And in between you have various types of NSIPs, fibrotic and cellular types. Yeah, that's what. So chronic fibrosing interstitial pneumonias, you have IPF, and some of the NSIP which are fibrotic are also chronic fibrosing. Acute or subacute would be acute interstitial pneumonia, that is Hammerich syndrome, or organizing pneumonia, and smoking related would be RBILD, DIP. RBILD, DIP are in the same spectrum, and you can have IPF also into this smoking related interstitial lung disease, Goodpasture syndrome, and many other things, right? So how do they present? Presentation is very non-specific, very vague pulmonary complaints. Most of them present with exertional breathlessness, cough which is usually dry, and some connective tissue features may be associated if there is a CTD ILD, like night sweats, fever, fatigue and weight loss. If they are there, possibly we are dealing with CTD related ILD. There are very few signs that suggest ILD, and if you have any of these things, possibly you are dealing with CTD related ILD, or in the clinical domain that I will come to in classification of the diagnostic criteria, these are also included in the clinical domain to make a diagnosis of IPAF or interstitial pneumonia with autoimmune features. These are the digital ulcerations, mechanic's hands, cotton patches, or Raynaud's phenomena. They go into the clinical domain of IPAF. So, once the clinical domain is over, radiologically, when we talk of the images in interstitial lung diseases, you have UIP pattern, you have NSIP pattern, you have organizing pneumonia pattern, LIP pattern. So a combination of this sometimes would be very, very confusing. So, but for IPAF, for the IPAF, you have to exclude UIP pattern. UIP pattern is not included in IPAF. So this is just a cartoon of all the changes that you see in the imaging. I'll come to it later. What is an UIP pattern? UIP pattern is you have reticular shadows, you have a subpleural honeycombing. Honeycombing is the one that decides between fibrotic NSIP and UIP. So you have honeycombing, you have traction bronchiectasis, reticular shadows that are subpleural in location with a cephalobasal gradient. So this is a typical UIP pattern. NSIP is again, you have a bilateral disease, symmetrical, subpleural sparing, you have a lot of ground glassing, you could have traction bronchiectasis, but there is no honeycombing. This is organizing pneumonia, where you have consolidation features which doesn't resolve with conventional antibiotics. And you have a LIP pattern, where you have diffuse ground glassing, cysts are interspersed, and then the cysts are around the blood vessels. So you have ground glassing, which is patchy, cysts, it is LIP. And what is the role of PFT in the management of idiopathic interstitial pneumonias? I mean, PFT is, there is no definite diagnostic pattern for interstitial lung disease, but most of the time you have a restrictive pattern, but you can also have the airways are involved, you can have an obstructive component, so you have a mixed pattern. But the most important thing is to have a baseline PFT measure. The lung function that is most important to monitor are the forced vital capacity and DLCO. And unfortunately, we don't have DLCO in our institute. And so is the case in many of the institutes. You have. So, but then many of the institutes in Hyderabad, we don't have DLCO. So that's a limitation. But anyway, so how do we approach to make a diagnosis in interstitial lung disease? This is a very busy chart, but we have to take a very good detailed history, right from birth to job to hobbies to drugs taken, and then bronchoscopy. Bronchoscopically, you rely on ball fluid and histopathology. If you have a transbronchial lung biopsy or mucosal biopsy, if none of them are diagnostic, then you go for a surgical lung biopsy. Maybe Jayachandra sir does a cryobiopsy. Yeah. So maybe cryobiopsy will be helpful in days to come. So, but then many times it's a multidisciplinary approach that goes a long way, where the pathologist, the radiologist, the surgeon, the physician, the rheumatologist, they all have to sit together and come to a diagnosis, right? So I'll see. So this was the article that we were interested in 1 year back. Just excuse me. So 1 year back, when we had this article in the Journal Club, we thought of doing some some work on this. So this is an article which done, the setting is in China. What they have done is, they have taken 10 years period, and then they have collected data of around 1,000 patients, and then they retrospectively analyzed this was at the end of 10 years, most of them are CTD ILDs. So they are CTD ILDs at the end of 10 years, and then they analyzed the data, what were they diagnosed initially in the first year. So this study showed that 32% of the CTD ILD patients did not receive accurate diagnosis on the initial presentation. So 32% were not CTD ILDs to begin with. Then 25.1% of these patients were antibody negative to begin with. So the seroconversion happened sometime later. So you have an ILD, you have some features of connective tissue, autoantibodies are negative, but over a period of years, they got converted. And 14% of these patients, the initial presentation was interstitial lung disease. No connective tissue features, no autoantibodies, only interstitial lung. So this was the article where we got interested, and we tried to do some retrospective analysis of our own data. So we come to IPAF of our institute now, our data. It is too early still, it is just a retrospective data. We need to follow them up. So we have 30 patients data. So we'll follow them up and see what happens to these 30 patients. So the data that we have collected for these 30 patients of these IPAF patients are, well, so how do we classify? I mean, how do we come to a diagnosis of IPAF? So there are some criteria that are laid down, and this criteria is based on the European Respiratory Society and American Thoracic Society guidelines, wherein they have presence of an interstitial pneumonia by HRCT or surgical lung biopsy. The patient should be having interstitial lung disease, and there should not be any other cause for this interstitial lung disease. Definitely there should not be no connective tissue clinically. So patient should have interstitial lung disease, no other cause, it is an idiopathic interstitial lung disease, no connective tissue clinically. But yet, if you have one from this domain, one from this domain, and one from this domain, or one from this and this from two domains. The domains are the clinical domain, serological domain, and morphological domain. So these are the domains that we have to consider. So whenever you have an idiopathic interstitial pneumonia patients, consider all these things and then follow them up. So I don't have to enumerate all those things, but they are all available. So that's it. So these are all the various workers that have recently been studying this entity internationally, and very little data from India. Rahul Sharma from India, he has done some work on this, wherein they said majority of IPAF patients were females, and most common serology was ANA and rheumatoid factor, and UAP was the most common in his studies, but ours is little different. So I'll just share my data, our data from our institute. So the gender-wise, yes, females are more common. So IPAF patients, females are more common, and anywhere from 30 to 60 years is the age distribution. Again, females are more common. The clinical domain included digital fissure, ulcer, arthritis, all those things. Dryness of mouth was something which is not mentioned in the ATS ERS guidelines, but we have a very common experience of dryness of mouth, but arthritis again is a very common clinical domain in our population. As against the other publication, where he said UIP is the predominant feature, but NSIP is the predominant radiological feature in our study. UIP we have not included because it's not part of the guidelines. So we cannot include UIP when you're talking of IPAF. Only NSIP, LIP, organizing pneumonia, or a combination of things. Okay. So the serological domains, the common is ANA and IgMRF, or anti-CCP, or is also positive. ANA, again, there are either speckled or homogeneous pattern. You have all those things. And yeah, that's what. So in the morphological domain, in the HRCT, we have 30 patients actually. So we have put it 27 because 3 of them are UIP. But UIP is not a feature, so that's how we have ended up with 27 patients only. So we have 25 patients who have clinical domain positive, serological 26. So all 3, I mean this is some data, all 3 domains in 14 and all that stuff. So these patients have moderate to mild restrictive disease, and they have certain comorbidities, hypertension and diabetes being common, and the hypothyroidism also very common in these patients. So in conclusion, majority of our patients were females, as I told you, emphasizing that IPAF is more common in female patients. So if you have a female patient with an idiopathic interstitial pneumonia, look into all the 3 domains, clinical, serological and morphological domains, and we can make a diagnosis of IPAF. And what does it mean to the patient of IPAF? That we'll come to it sometime when we talk of management of IPAF patients. So it is very important to rule out an autoimmune cause of ILD in all ILD patients, even if it's not associated with clearly defined connective tissue, especially for pulmonologists. We may not be experts in making a diagnosis of connective tissue ourselves, so we need to take the help of our rheumatology colleagues if we have missed any clinical features. Most of the patients were diagnosed as either obstructive airways disease patients or IPF patients or pulmonary tuberculosis patients that came to us, where we finally diagnosed them as IPAF. And as I told you, the most common spirometric abnormality is restrictive or a mixed pattern. And most common symptom in the clinical domain with interstitial lung is, apart from cough and breathlessness, is arthritis. Most of our patients had NSIP pattern and significant ground glassing on HRCT, indicating ongoing inflammation. Most common autoimmune profile is ANA positive followed by rheumatoid factor. And most common comorbidity again is hypertension followed by hypothyroidism and diabetes mellitus. Multi-compartment involvement is rare. Multi-compartment is presence of pleural effusion or pericardial effusion or vasculopathy. So this is a multi-compartment or an airways disease, major airways disease. So this is a we did not appreciate that. So most of the patients that came to us already had pulmonary arterial hypertension. Thank you. So interstitial lung disease, especially in the females, idiopathic in nature. Think of all those domains. Make a diagnosis of IPAF. What does it mean? It means a lot because treatment is little different, prognosis is little different, and maybe when we follow them up, some of them will develop overt connective tissue. We don't know. When we have that data, we'll present to you. Yeah, any questions on this? Yeah. I know it's already late. We can make some reasonable diagnosis of sarcoidosis on plain chest X-ray. But most of the chest X-ray, you have reticular shadows and then little honeycombing, little small lungs. Some of the ILDs can have a maintained lung volumes, but usually fibrotic ones will have smaller lung volumes, pulmonary arterial hypertension. Some patients came with the pneumothorax, spontaneous pneumothorax, females, lymphangioliomyomatosis, Langerhans, histiocytosis in male smoker, they come with pneumothorax as well. And then connective tissue related changes, esophageal dilatation, are better appreciated in CT scans than plain chest X-ray. So yeah. How does correct. How does it differ from CTD ILDs? No, it doesn't. It doesn't really, because we treat them with steroids, and if steroids cannot be given, we have managed with cyclophosphamide, MMF. It really doesn't matter. But then, as we keep studying this disease entity, we still do not know whether this is going to be a separate entity in days to come. This is a new term. Will this term itself will stand the test of time, we don't know. Previously, they used to call it as connective tissue related ILD or lung dominant ILD or autoimmune featured interstitial lung disease, and then IPAF is a new term. Treatment wise, it's not very different from connective tissue disease. It's steroids, cyclophosphamide and MMF, and most of them seem to be doing better. Yes. And the response is little better if the clinical domain is predominant. Response is not so good if the radiological domain with the fibrosis is more. So, or if there is the textbooks, or in the, not in the textbooks, in the literature, say if there is multimodality involvement, then the response to treatment is poor. Yeah. Lung transplant. Lung transplant, end-stage fibrotic lung disease may be an option, lung transplant. But lung transplant, as on today, is predominantly reserved for IPF, where no other treatments are available. The autoimmune related interstitial lung disease, they respond well to steroids or immunomodulated drugs. Yeah. So, lung transplant may not be a solution in CTD related or IPAF, but IPF, yes, or fibrotic NSI, or some other lung disease which are end stage, say occupational lung diseases, interstitial lung disease in occupational silicosis. So maybe there you have an option of lung transplant, not in connective tissue or IPAF. Yeah.
I was a transplant consultant in Manchester doing heart and lung transplant. See, for the lung transplantations, they are very difficult subset because you are constantly exposed to air. Therefore, the infection risk in lung transplant is very, very high. The group of patients who have had the maximum benefit for lung transplantation in particular are patients with cystic fibrosis. That subset do well. The other subsets don't do that well. So, lung transplant is the last modality which has to be considered. So, just wanted to make that little note.
I mean, there are no specific radiological or clinical features to suggest that this pattern is drug induced. No, but then it's the clinical history that helps us. Some of the drugs are notorious to cause interstitial fibrosis. So if you have that history, stop the drugs, and then follow it up with spirometry, forced vital capacity, or DLCO. That's the only way we can follow them up. So stop the drug. If you suspect a drug-induced ILDs, say methotrexate or amiodarone, or even your radiation-induced fibrosis or recall radiation fibrosis, but if you have all those things, there's no specific treatment as such. Just remove the offending drug, just follow the patients. Yeah. And there are no specific radiological or clinical features to suggest that this is due to this drug-related. No. Yeah. Ball may show some foamy macrophages to suggest, but then that's not very specific.
Thank you very much, sir. Can I request Dr. Shashidhar Reddy, our internal medicine consultant, to give a memento to sir? Both of them know each other quite well.
We missed introduction, just a few words regarding Prabhanajit sir. Sir has started, actually it was initiated by Manmodrao sir, Department of Pulmonology. But after Paramjyoti sir has come, department has started fully functionally with 2 postgraduates, and sir is very much interested in research work rather than just teaching. And as I was a registrar at NIMS, I learned many things in pulmonology from sir. Welcome to Century sir, and thank you for the nice talks.
We just had an inspection from MCI. If everything goes well, we might start a DM pulmonology. We don't know. Just pray for that. And if it happens, it's going to be first of its kind in government setup in south of India. We have one in St. John's, one in Amrita Institute, DM Pulmonology. So it happens in NIMS, first of its kind in government setup.
Yeah, with this we come to the end of the CME program, and any further interaction you're welcome during the lunch break. I think we'll adjourn for lunch at this point of time. And let me thank you. You've been a wonderful audience. I am sure this comes from all of us here. All of you have been very patient, trying to listen. I don't know how much you gained from the lectures that you've just heard. I'm sure most of them were quite informative, and I'm sure a little richer by the experience. Thank you very much.
Photo दिया सर
digital media for spreading awareness and medical information.
Hello.
The new digital medium of spreading awareness and also medical information to doctors, to patients, to stakeholders in the health industry, I think is a new, innovative and extremely useful and powerful resource. The live coverages, the web coverages by India CME have been most innovative in terms of getting the medical knowledge across the country and then probably internationally as well. Many a times good programs can be held in hospitals, but they might not be accessible to all concerned and all interested because of logistic issues that as to where it is held and where the doctor is, particularly if the doctors are in tier 2 and tier 3 cities. So these kind of web-based programs or continued medical education sessions will be very useful for them. At the same time, I think the industry can use this platform to be able to get interest and also create awareness and pass on the information about the new technologies to a very, very wide based audience. And I'm hoping that in the future even patients will also get benefited from these lectures, because many of these lectures in today's age even patients can understand. So I congratulate India CME for doing this web-based platform and supporting continued medical education across the nation and hopefully internationally as well.